Good morning. Good morning. Good morning. Good morning. Good morning. Good morning. Good morning, everybody. Thank you so much for joining us. We really appreciate you taking your time to join. Our call has now officially started for this wonderful day's meeting. I am Samuel, and welcome to the Jamaica Association of Nurse Anesthetists Healthcare in the Digital Era webinar. We thank you so much for taking the time to join us today. We're looking forward to a wonderful series of presentations. Many of our presenters are on at the moment. We are actually just waiting a little bit to have a few more of our panelist members join, and then we will start. So I ask you to just give us some time. Thank you so much for joining. We'll be with you shortly to officially start, but you're in the right place.
Happy to be here to start us off on our webinar this morning, which we're focusing on information technology. So I want to welcome all the persons that are on this platform this morning. And it's an awesome privilege to be alive this morning and to be here. So as with all things, we must invoke and invite the presence of God in our midst. Amen? So this morning, we're going to be having a very brief devotion. And the devotion this morning speaks to PERS. Our topic this morning is God-sized PERS. I feel like I'm talking to myself. Everyone hearing me?
I'm hearing you. We're
Yes,
hearing
good
you.
morning.
We're all hearing you. Good
We're
morning.
hearing you.
All right. So our topic this morning is God-sized PERS. And our scripture comes to us this morning from St. James chapter 4, verse 2, and it's a New International Version. It says, "Yet you don't have what you want because you don't know how to ask God for it." How you pray determines what kind of life you live. If you only pray small, ordinary get-by prayers, then you'll have a small, ordinary get-by life. But when you have the boldness to ask God for big things, when you pray God-sized prayers, you will see the greatness of God's power. All through the scripture, we see the principle. Elijah prayed that it would rain, and for 3.5 years, there was no rain for 3.5 years. Joshua prayed for extended daylight, and God stopped the sun. Elijah prayed for protection from his enemies, and they were blinded. The common denominator is that we ask God to do the unthinkable. If you are to reach your highest potential, you have to have the same boldness. One reason we do not see God do great things is that we ask only for small things. There should be something you are praying for and asking for that seems impossible, far out, something that you cannot achieve on your own. What God-sized prayer are you asking for Him today? Dare to ask. Let us pray. Father, thank you for the peace that passes all understanding, so we can be calm in the midst of our storms. Thank you for your daily care and protection. Thank you for bringing purpose and new beginning into our lives. We thank you that you created us to live an abundant life, not a small life. Thank you for the challenge to pray God-sized prayers and to see the greatness of your power. Help us, dear Lord, to dare to ask big and to believe for what seems impossible. In Jesus' precious name I pray. Amen. So to get things started off this morning, I'm not sure if you're able to share the program on the screen. Are we able to share the program on the screen?
Not at the moment, but I'll put it in the chat so everyone can see what the day looks like.
Okay, thank you so much.
No
So
problem.
at this time, I'm going to be inviting Mrs. Carol Farquhar-Smith, President of the President of the Jamaica Association of Nurse Anesthetists from the Savannah Public Hospital, to bring us greetings.
Mrs. Farkas-Smith.
Good morning. Are you hearing me?
Yes, we are.
So good morning, everyone. I'm happy to welcome you to our 2023 Jamaica Association of Nurse Anesthetists webinar under the theme Healthcare in the Digital Era. The digital era started around 1980 with the internet, after which we had the mobile devices, social networking, computing, clouds, and big data. Revolutionized work practice has been established as a result of digitalization. This, of course, impacts healthcare. During COVID-19, digitalization burst the seams and has changed the way we educate, care for others, socialize, do business, among so many other areas. Today, we are faced with the challenge of artificial intelligence and its possibilities, which seem endless. So enjoy, be informed as we share in this webinar. Our presenters has a fascinating, very informative and interesting set of topics lined up for us today. So thank you again for coming. Have a great webinar and a great day. On behalf of the Jamaica Association of Nurse Anesthetists, welcome. Thank you.
Thank you very much, Mrs. Carol Farkas-Smith. I have a thought that I would like to share with us today, and it says, the secret of change is to focus all your energy, not on fighting the old, but on building the new. And this is a quote that was scribed by Socrates. And as we talk about the digital area and how we move into managing, it is a new phenomenon for a lot of us. And some of us are frightened and unsure, and we do not know how to proceed. But it's a new change, it's a new thing, and change is always good. But the important thing is to embrace it with a positive attitude. So today I want to encourage us to focus our energy not on fighting, right? We're keeping the old in place, but on embracing new ideas, new practices, and new systems. So at this time, I'm going to invite Miss Kimari Brown, a nurse educator from the University School of Nursing, to speak to us on electronic health records. What could possibly go wrong?
Good morning. Thank you. Let me go ahead and share my screen. So good morning again. My name is Kimari Brown. I am a registered nurse and a lecturer in health informatics at the UWI School of Nursing, Mona. I am delighted to talk to you this morning about electronic health records and what could possibly go wrong. And if you know me, you know that I don't like to dwell in the problems. And so as I go through those things that could go wrong, I'll be presenting a few solutions as well. Right. So can any of you think about a time before the smartphone? Better yet, can any of you think about a time before cell phones was as common as they are today? Healthcare is seeing a similar evolution in the use of technology at the bedside, and sometime in the near future, it will be very hard for healthcare workers to imagine how they even managed without the use of technology. All right, so my goal for this presentation this morning is to educate, inspire, and empower every attendee to become meaningful participants in Jamaica's evolving health information technology space. To do this, I will need to give a brief overview of health informatics. I will outline healthcare applications of information technology, and finally discuss issues surrounding the implementation and use of electronic health records. So, what is health informatics? Now, at its most basic, it is the science and art of turning data into information. Now, I love about this definition is its simplicity. How we turn data into information may not be as simple all the time, but luckily for us, we are in the technological age and we have technology to help us to do that. Now let's look at another definition of health informatics. What I like about this definition is that it goes into the nitty-gritty of what health informatics is, and I also love it for that. It reads, health informatics is the application of computer and information sciences in all basic and applied biomedical sciences to facilitate the acquisition, processing, interpretation, optimal use, and communication of health-related data. So let's break it down. First, I want to draw your attention to the fact that this definition highlights that health informatics is a broad area of focus, because in the second and third lines, it says that it applies to all basic and biomedical sciences. So, in the same way, healthcare can be used to refer to the delivery of medical care, nursing care, physiotherapy. Health informatics encompasses several biomedical disciplines. This definition also tells us that informatics is the use of computers and information sciences to help us to do many things with health-related data, such as interpretation and use of this data. No, what I tell my students who tend to have a little fear of the computer is that the computer is not the focus. The focus of health informatics, or the reason we are using these computers and information sciences, is for our patients and the processes involved in caring for them. The patient is the star of the show, and the computers and the information sciences and the information systems, those are the supporting actors. And we use these tools to help us to get to the goal of improving the quality of care. We also use these tools to help us to be more efficient and safer in the way that we provide care for our patients. Every new technological device or software an institution implements should help the organization to meet this goal of enhancing the quality, efficiency, and safety of patient care. In other words, the technology we used must help us to make patient care better. It must cause us to work more efficiently, and we all know that when we are efficient, we get more things done in less time. But I must caution you, we are not sacrificing safety at the altar of speed, because when we use the computer and information sciences, we should also be providing care that is safer for the patient. So let's look briefly at how information technology can be applied to healthcare. All right, so I am tempted, because this is the area that I am most interested in. I am tempted to go into a deep discussion on each of these areas, but unfortunately, the time will not allow me to call. Sorry about that. But unfortunately, the time will not allow me to go into a deep discussion about each area, so I will only call them by name. So in healthcare, we utilize health information systems to maintain patients' electronic health records. We also have clinical decision support systems, which are automated tools designed to support decision-making activities and improve the decision-making processes and outcomes. Clinical decision support systems smartly filter through patient records, which exists in an electronic health record, to push forward those data that are necessary to make a clinical decision. So for example, an alert that is generated for a prescriber who attempts to prescribe a drug which a patient has a documented allergy. Another example comes in the form of documentation prompts to a nurse to enter the patient's heart rate in the electronic health record before he or she administered the digoxin. The COVID-19 pandemic has fast-tracked the application of information and communication technologies in delivery of healthcare, as in the case of telemedicine, teleradiology, telenursing, and so on. Restrictions in physical gathering due to the pandemic also saw an increase in the use of ICT to provide education and continuing education. The fact that we are gathered here today serves as proof of the positive impact IT is continuing to have on health education. Even with a small glimpse into the world of health IT, it is clear that many things can go right. However, without adequate planning, implementation, and monitoring, things can go wrong too. So for the remainder of my time, I'll be discussing three major issues that have the potential to affect negatively the use of electronic health records. So what could possibly go wrong? So let's start the discussion with EHR system design. All right, so one of the main purposes of implementing electronic health records is to help to create a steady workflow in the practice environment. Unfortunately, sometimes EHR implementation disrupts the workflow in a practice entirely if it is not customized to the practice environment. So what we mean is that we can't just pick up and cut and paste a system into an institution. So to avoid disruptions in the way healthcare providers provide care, it is advisable that institutions ask or request a demonstration from the vendor of how the implementation will work in current practices. The second thing that could go wrong in terms of EHR system design is complicated user interfaces. And the user interface is what the end user or the nurse, the healthcare provider would see when they log into the system. Now, complicated EHR interfaces can lead to missed information. There's a lot of information available on each patient and with many different screens for healthcare providers to navigate. Time constraints, particular in high acuity settings such as the ER, ICU, can make it hard, if not impossible, for healthcare workers to see all the information needed to safely treat patients. This can lead to missed test results, missed allergy alerts, and other safety-related mistakes. Simplified, integrated interfaces, and using decision support systems to push critical information to the healthcare provider at the point when the information is needed are useful solutions to this challenge. What this means is, instead of having to search through the system to locate the patient's allergies, the system using decision support pushes that data at the points when it is needed. So for example, at the time of medication prescription, when the prescriber is attempting to prescribe the desired medication, right? Information regarding patient allergies using decision support system can be pushed at the time of dispensation. So that is when the pharmacy is preparing to dispense the medication for the patient, and also at that final point of administration. So before the nurse administers the medication, decision support systems can be used to push critical information such as patient allergies for the attention of the nurse who is about to medicate the patient. Another challenge arises when EHRs don't talk to each other, and this is a huge challenge. And what this means is that when we say that healthcare information systems or EHRs don't talk to each other, we say that there's a lack of interoperability. So remember that word. Interoperability means that healthcare information systems don't communicate with each other. So by way of example, the EHR in Hospital 1 cannot read the data it receives from Hospital 2 about the same patient because the systems are not interoperable. They can't speak to each other. In extreme cases, there is a lack of interoperability between departments within the same institution. Interoperable systems are imperative for safe and effective patient care as it eliminates information silos. When healthcare providers can share patient information digitally between information systems, they're able to make more appropriate and safer patient care decisions. Now, as Jamaica moves closer to having universal electronic health records, it is important for us to learn the lessons from countries like the United States who have already encountered these challenges and have already developed solutions. Considering the vast healthcare ecosystem locally and the variations in available systems, this challenge is inevitable unless standards for interoperability are set and adopted across all institutions. Now, one of the things I like to say is that I'm not lazy, I am efficient. So I like to get things done in as little steps as possible. And the efficiency of a system can be measured by the number of clicks it takes to complete a required task. When there are too many clicks or steps in a system, right? Healthcare providers begin to integrate workarounds or shortcuts to get to the desired destination faster, right? Because as we say in healthcare, time is muscle. Invariably, these workarounds bypass critical safety checkpoints, which may increase the likelihood of patient harm. System developers can fix these challenges by conducting extensive testing to ensure that processes can be completed efficiently. Now I'll be talking about EHR system security. There's a lot I can say here, but I'll do my best to keep it concise. So, in preparation for this presentation, I did a simple Google search using the following terms: health information system security breaches. Now, not surprisingly, there were millions of results. Admittedly, the volume could have been due in part to poor search strategy. However, after perusing a few of the top articles and doing a quick check to ensure credibility, it became clear that breaches in healthcare information system security is a major challenge that continues to plague healthcare institutions. According to Halsall, in a 2021 Gleaner article, healthcare breaches increased in Jamaica 55.1% from 386 in 2019 to 599 in 2020. It would be interesting to see what more current figures look like. Hacking, IT incidents, and unauthorized disclosures are the more common reasons for these breaches. So, the article continued by stating, Healthcare institutions have to take particular care to prevent being compromised because patient data is highly sensitive and valuable. The average cost of a data breach incurred by a non-healthcare related agency per stolen record is US $158. For healthcare agencies, the cost is an average of $355 US. For context, credit card information sells for $1 to $2 US. So let me say that again. Each person's health-related information can be sold on the black market for as much as $363 US, compared to $1 to $2 US for credit card information, right? That's a lot of money. These potential earnings from the sale of this data are why the health sector is often targeted. While people can change credit card information, for example, to counter this problem, health information, patient history, name, and other personal details cannot be changed. In March 2022, the Gleaner covered a story in which it was alleged that the EOJ sold voter registration data. While the claims have been denied, and this is not a healthcare related example, it is a perfect example of the value of data. In the same way, advertisers use your browsing history to tailor ads aimed at inducing a purchase, healthcare data are extremely useful in the area of precision medicine and data mining. So consumers of healthcare data will either buy it or steal it. It is for this reason securing personal information represents a major concern in today's society amidst the growing reports of stolen and compromised information. So let's talk about what could go wrong in terms of an electronic health record. So we've seen as recently as June of this year where institutions in various sectors have been the victims of ransomware attacks. A ransomware attack occurs when the information system is hijacked and the hijackers demand a payment of a ransom to restore access to the institution. Now, I want you to imagine not having access to your patient's health records, yet alone a critically ill patient. Imagine not being able to see the patient's most current lab results. Imagine not being able to check the system for the patient's allergies. Imagine the patient requiring an urgent intervention and not being able to use the information system to push through that order for that urgent intervention. Lives could literally be lost if our systems are hijacked. Information system security planning starts when an institution begins to plan for the electronic health record. It is important that institutions conduct an analysis of possible threats to information system security and plan accordingly. Additionally, threats to information system security and information availability should also be assessed. So, for example, what are the plans for backup electricity, right? These are computers, they're electronic devices. How do we proceed if there is no electricity to operate and or charge these devices? What are the contingency plans in the event that access to the system is lost for whatever reason? So, one of the fixes to malware and ransomware is robust end user education, because malware, it's not like a virus that's circulating in the air. It must be introduced to the system, and people is how it gets into the system. Clicking on a link, downloading a particular document, accessing a particular site from the computers that house the information system. So robust end user education regarding system security is a must. Another thing that could go wrong is stolen or misplaced computers and or tablets. Healthcare institutions can take inspiration from retail, where a fix for this challenge is concerned. Embedded devices that alarm if the device passes a threshold can be utilized. So for example, when you go into a store, if someone in the store attempts to remove an item before paying for it, you hear an alarm blazing. A similar technique can be applied to securing the devices in the healthcare system. Also, tracking software similar to Samsung's and Apple's Find My Phone can also be used to recover or misplaced or stolen devices. I remember when the government of Jamaica introduced the tablets in schools programs, and tablets started to go missing. Using similar device tracking software, the government was able to track the location of these devices, and some were not even located in Jamaica, right? So these software can help us to locate missing devices. Also, specialized computer terminals that are secured to a mobile trolley makes it more difficult for computers to be removed. Now, the last thing I want to talk about here are data that are stored digitally is easy to share. That's a good thing, but it becomes a disadvantage when the sharing of data breaches confidentiality. In the US, the protection of healthcare information is mandated by HIPAA and the Joint Commission requirements. In June 2020, the Data Protection Bill was passed locally in our Senate, and the act seeks to safeguard the privacy of personal information, and it extends to the protection of healthcare-related data. The Data Protection Bill provides guidelines on how personal data should be collected, processed, stored, used, and disclosed in physical and electronic forms. It requires that data should be only obtained for a specific lawful purpose and the consent of the individual, and not be further used or processed in a way incompatible with the original purpose. The legislation also stipulates that the data collected must be accurate and, where necessary, kept up to date. The data must not be held for longer than is necessary and for the original purpose, and it must be protected using appropriate technical and organizational methods. The data must also be disposed of in accordance with regulations. So, as institutions, we have a role to play in the protection of the electronic data in our electronic health records. Though the Data Protection Act is not as extensive as HIPAA, it is a step in the right direction. So let's look at a few challenges associated with EHR implementation. All right, they are few in numbers, but significant. Limited access to data or no access to the electronic health record, and too much access. They are similar challenges which share a similar solutions. So institutions should be concerned with limiting the access to patients' healthcare information to a need-to-know basis in order to maintain patients' confidentiality. By implementing what we call levels of access, the institution can control the degree of access each user has to a patient's electronic health records. This limits each user's ability to view a patient's record based on that professional's scope of practice. Additionally, some users may need to see patient information but are not granted editing privileges, as in the case of students and educators in healthcare disciplines. Right? So we have a challenge, we have a potential challenge with having too little access no access at all, or too much access. And the fix to that is levels of access. I am going to close out this discussion with a discussion on challenges associated with the actual data in the electronic health records. Now, I am a nurse, so I will be referring to specific nursing languages, but the same principles are applicable to other healthcare disciplines. Now, the major challenge with EHR data is the non-adoption of standards for documentation or standardized nursing languages, such as the International Classification of Nursing Practice or ICNP, other languages such as NANDA, which we should all be familiar with, NIC, which is the Nursing Intervention Classification, and NOC, which is the Nursing Outcome Classification. In the absence of nursing data, nursing care is often measured in negative qualities such as adverse events. These adverse events are called outcomes potentially specific to nursing, which are medical diagnoses that may measure the contribution of nurses in providing care. These are negative health consequences which arise from inadequate nursing presence with the patient. They include urinary tract infection, pressure ulcers, pneumonia, and pressure falls. The U.S. Department of Health and Human Services studied data from 5 million patient discharges, and the result of that study demonstrated that more registered nurses resulted in fewer consequences or fewer occurrences of these outcomes potentially specific to nursing. Interestingly, though, when a patient does not develop a pressure ulcer, or when a patient does not develop hospital-acquired UTI, this is not automatically attributed to stellar nursing care. Now, we know that this is the case, but it's not enough to know. We need to use data from nursing documentation to prove it. What this is reinforcing is the need to document what we do in a way that makes it possible to objectively demonstrate the positive outcomes that are achieved through nursing care. So we know what happens when nursing care is inadequate. Now we need to know what happens when nursing care is adequate. Nursing documentation throughout the period of a patient's admission can be a very powerful tool to measure patient outcomes, both positive and negative, and it is useful for communicating information on the patient's status throughout the admission. Nurse researchers can use nursing documentation to impact nursing care. Nurse researchers can use nursing documentation to study the impact nursing care has on patient outcomes and to create new knowledge by showing how traditional practices impact patient outcomes. In order to unlock the potential that nursing documentation has, nursing documentation needs to be retrievable, comparable across all settings, and measurable. The traditional narrative way of documentation in which each person has the liberty to use their spoken language to document what they see in the way they see fit does not allow for easy retrieval, comparison, and measurement of data across settings. Now, some of you here today may be quality assurance personnel, so that point probably resonates very strongly with you. The inability to easily compare documentation across settings is a significant challenge when there is non-adoption of standards for documentation in an electronic health records. Our limited ability to retrieve and use nursing documentation for research means that what nurses do and how nurses contribute positively to patient outcomes is impossible to determine, and that is a big problem. Standardized nursing languages facilitate measurement and comparison of nursing care and patient outcomes because standardized nursing languages eliminate the differences in expression which can occur when nurses document in their own way. So this brings me to the end of my presentation. I want to thank the Jamaica Association of Nurse Anesthetists for inviting me to speak to you this morning. I want to also thank you for your attention. And Madam Moderator, if it is now time for questions, I will take those.
Thank you very much, Lady Brown. A very wholesome and informative presentation. I will allow 5 questions from our attendees, but I will have the first one. And the first one is that you spoke about data storage and the data that is to be held. How long is the recommended time for this electronic data to be stored and held?
All right, so that's an excellent question, and it really just it depends on the industry. So in research, for example, 5 years is the maximum, but because of what we do in healthcare, we cannot discard the patient's information after 5 years. We need the patient's record for their lifetime, right?
Mm-hmm.
So the answer to that question, it just really depends on the industry. Now, how long after a patient's death should the information be retained is another question. And that standard or that time frame is usually something that is set by law. I am not sure that the Data Protection Act addresses that question specifically. So it would be up to the institution to implement policies that guide how long after death can the or should the information be held for.
Okay, thank you so much. Are there any questions from the floor for our attendees? Okay, thank you very much, Lady Brown. Moving right along. We will now invite Dr. Xavier Brown, obstetrician and gynecologist at the University Hospital of the West Indies, to speak to us about telemedicine, obstetrics, and gynecology. Dr. Brown? Is he on?
I think he's on, but I believe our next presenter is Nurse Kushney.
Dr. Brown is on.
No, our next presenter is Dr. Brown. We have electronic health records, then Dr. Brown, telemedicine, obstetrics, and gynecology.
Okay, hello, are you hearing me?
Yes, we're hearing you, Dr. Brown.
Start your camera, please.
Pardon?
Open your camera, sir.
Okay, I'm coming. I'm just trying to share my screen. I'm just trying to share my screen.
Dr. Brown, are you having challenges in terms of sharing your screen?
Yeah, he is, because his internet seems to have given him trouble. He's actually off the call at the moment. But we want to thank everyone for joining. Thank you so much. It was a wonderful first presentation and question and answer session. We're hoping to see Dr. Brown rejoin us shortly.
Okay, could we...
Madam Moderator?
Could we move? Yes, ma'am. Mrs.
May I use this downtime to address a comment in the chat from Mechanic Golding?
Sure, let me go right ahead.
All right, so the comment was also give patients a copy of their medical records each visit, maybe not every detail, but a summary and their last vitals. Now, that's an excellent comment, because with electronic health records, in the same way that banks have their information system and the interface that the banking worker has, and the customer has their own section of the system, electronic health records can be designed in the same way, where patients have access to a patient portal. It is actually advised so that patients can actually see their health record and bring discrepancies to the attention of the healthcare provider. So that is a most important feature of the electronic health record. Thank you.
Thank you very much. Dr. Brown, are you back with us? Dr. Brown? Dr. Brown, are you able to hear us?
Dr. Brown, you're muted, sir. So we see where you've shared your screen. Thank you. We'd also like you to just unmute, please. You should see the request coming from me for you to unmute.
Okay. Hearing me now?
Yes, we are.
Okay, awesome. Just get this up. Are you seeing the presentation? And I'm coming through clearly. Okay. So the moderator, fellow panelists, ladies and gentlemen of the audience, good morning. I'm Dr. Xavier Brown, obstetrician and gynecologist, and I'm to discuss with you today telemedicine and its application in obstetrics and gynecology. So our objectives, we're going to define telemedicine. We're going to try and understand the history and its current use of telemedicine in obstetrics and gynecology, and to review the role of telemedicine during the COVID-19 pandemic, and also to establish the role of telemedicine in the future. Now, telemedicine is a broad term referring to the use of communication and information technology to provide remote clinical services to patients. It encompasses a technology-enhanced healthcare framework, including services such as virtual visits, artificial intelligence, behavioral economics, and mobile healthcare. However, despite the ever-growing presence of telemedicine within the healthcare system, a definition incorporating all of its aspects remains incongruous, both in the literature and between healthcare systems. For example, in the American literature, it separates the definition of telemedicine from telehealth, where telemedicine is often used to refer to the traditional clinical diagnosis and monitoring that are delivered by technology, while the term telehealth is now more commonly used to describe a wider range of topics, such as diagnosis, management, education, and other fields of healthcare. Telemedicine modalities should not only include patient-to-doctor interactions, but also the interactions between healthcare professionals. Some would argue that a medical education and research method should be considered within the definition because they are vital components to the delivery of healthcare. But the overall aim of telemedicine is to really enhance decision-making, training, medical education, and remote support, thereby enhancing the options by which healthcare is delivered. But I digress. Telemedicine may be further subcategorized as synchronous, which is a live two-way audio and video interaction, allowing specialists and local physicians and patients to see and hear each other in real time to discuss conditions. It may be asynchronous, also known as a store and forward, where medical images such as x-rays, photos, ultrasounds, recordings can be sent for interpretation by the specialist and also to aid future medical consultations. Remote patient monitoring. This collects personal data and medical data from an individual in one location and electronically transmit the data to a physician in another location. Remote patient monitoring may use medically designated handheld devices or wearable devices to collect health data remotely, or may use smartphones and applications that leverage wireless or Bluetooth technologies to track patients while they are away from the clinical setting. Now, what comes to mind readily, for example, is a Holter monitoring. So instead of having the patient wear the Holter for 24 hours and it records, then you can record it in real time, or as is done now, it is read by the specialist after completion of 24 hours. mHealth, or mobile health, is a general term for self-managed patient care, using mobile phones or apps or text messages or wireless technology that not necessarily involves monitoring by a physician, but reminders to the patient, reminders to take medication, reminders to stop smoking, etc. A little in the history of telemedicine. Now, telemedicine arose out of the challenge where medical care was limited to the radius in which the physician was available, or where patients and providers had to be co-located. This drove the cost of health due to the need to relocate people and equipment, distances involved, and the speed of information transfer. Now, it's important to understand that telemedicine began as early as 1451 when Johannes Gutenberg invented the printing press, and this allowed healthcare providers to disseminate information en masse. The use of technology to deliver remote healthcare has been a long-standing component of modern medicine. From the early 20th century, when Ethoven used analog telephones to transmit electrocardiograms and electroencephalograms, or EEGs, to the more recent use of teleradiology to view remote images and telesurgery, to mentor or even perform remote surgery via robotics. Now, more specifically, telemedicine in obstetrics. The use of telemedicine as a modality within obstetrics was first described in 1979 by Bohm and Hare, where the transmission of fetal monitoring data through a telecopier to a tertiary care institution allowed for remote fetal evaluation with a view to providing remote expert opinion. After examining the literature, I have recognized 4 pillars from which telemedicine in obstetrics can be viewed. The first, remote obstetric consultations. Now, it's important to understand that there is limited evidence regarding the benefit, patient satisfaction, and cost analysis that may justify considerable infrastructural restructuring on a large scale. Yet, there's a body of evidence highlighting its potential in certain areas. For example, a systematic review by Hilgard et al. In 2012 assessed literature within the field of prenatal genetic counseling, and the overriding themes suggested equivocal patient satisfaction with no obvious detriment in clinical outcomes. The studies involved were again limited and mostly included small numbers. But of importance, clinicians also noted concerns about their overall satisfaction, development of rapport, and the ability to evaluate patients' nonverbal cues during remote video consultations. Further studies have suggested that some of these concerns stem from being unfamiliar with technology, barriers that really can be overcome with time and training. The second pillar, remote monitoring in obstetrics. Now, this is usually applied to low-risk pregnant women attending numerous visits, and they're asking, why do I have to come so frequently? If they're low risk, then there is a role for remote monitoring. Also, integrated models of care have been proposed. Virtual consultations can be combined with the woman's use of home monitoring devices to track fetal heart rates, maternal blood pressure, fundal height, and then transmitting these data for analysis. And this is really practical. For example, if the patient is a nurse, she knows how to do her blood pressure, she knows how to do her urinalysis, she knows how to do her fetal heart rate. So there is a role for it. A retrospective study of gestational hypertensive patients by Lancels in 2017, which compared remote telemedicine with conventional care, and what they observed, there were fewer unscheduled visits and also fewer medical interventions. The third pillar, teleultrasound and remote surgery. Now, challenges include a sufficient local skill set for image acquisition and managing complex cases remotely. So for example, if we have a patient that needs a second trimester ultrasound, particularly by a maternal fetal specialist. Now, if the patient is particularly at risk for fetal anomalies, for example, uncontrolled diabetes, advanced maternal age, history of a fetal anomaly, but the patient really cannot afford transport to the location of a maternal fetal specialist. An ultrasonographer may be able to carry out the ultrasound while being viewed online by the fetal maternal specialist. But the challenges include getting the exact views for interpretation. They just may not possess that skill. Furthermore, robotic surgery within fetal medicine may allow for wider access to a limited number of highly skilled practitioners via telesurgery. And finally, obstetric counseling. Now, pregnancy, as you would imagine, is a journey. And patients may need a little additional support. So really, obstetric counseling, it aims to initiate and or reinforce positive self-care behaviors and to answer any questions that the patients may have, questions that may arise overnight. But that can be answered. The patient does not necessarily have to come in. Now, inadvertently, this is already happening through the use of WhatsApp, through the use of a telephone conversation, or even a Zoom call. Okay. Now let's move on to telemedicine in gynecology in particular. Just as in obstetrics, there is an increasing interest in the use of telemedicine modalities for the management of gynecological conditions. The data suggests that waiting times for outpatient care and the initiation of treatment can be significantly reduced with the introduction of telemedicine modalities. A systematic review by Ender et al. In the field of medical miscarriages suggested patient satisfaction with the use of service, increased ease of access to obtain a medical abortion, and non-inferiority in safety outcomes. Now, even though medical miscarriages are taboo almost globally, a lot of studies with telemedicine and its effect in gynecology were done with managing patients who have had a medical miscarriages or just in general follow-up. Virtual clinics for the management of urinary incontinence disorders are also being evaluated, while the remote monitoring and mHealth has preliminary evidence improving adherence to exercise regime, incontinence quality scores, and patient education. So particularly with the incontinence person or the incontinent patient, where you would want to track the bladder diaries, the number of episodes they've had. Really, they don't have to come in to a physical consultation because that patient would have already been examined. We just need follow-up and demonstration of progress or assessment of progress. So this really and truly helps to decrease the cost of accessing healthcare. But then there are also challenges. Telemedicine, particularly in the management of gynecology malignancies. This is particularly important in large countries with vast geographical areas where specialist medical care is concentrated around and densely populated in urban areas. Now, this can be applied to Jamaica, especially as it relates to gyne-oncologists. Gyne-oncologists are really concentrated in Kingston. They may have occasions where they go to remote hospitals to perform surgery, but really and truly access to the necessary chemotherapy drugs are centralized in the urban areas. Now, a natural barrier to high quality gyne-oncology care in remote areas. The evidence suggests a correlation between increasing distance from a specialist center with decreased uptake. So you may have a patient diagnosed with cancer, but just because they have to take 3 taxis to get to the town center of that remote location, and then 2 buses to get into Kingston, the patient may not be interested, and they may just be looking towards the light, getting their house in order, and getting ready to die. They feel defeated before they even start management or started the race to recovery. Multidisciplinary meetings can occur via virtual video conferencing, linking the specialists and the surgeons from the referring hospital remotely and allowing coordination of patient care. Now, this enables surgeons locally or gynecologists locally in a remote institution to effect the initiation of management through discussions, live discussions with the gyne-oncologist and other members of the healthcare team. Should general surgery be involved? The oncologist, the hematologist, should the hematologist be involved? A discussion can be had and a plan made for the patient and the care effected from the local or the remote site before the patient is even transferred. Now, there are, however, potential drawbacks as there is considerable concern regarding the inability to conduct physical examination. But one solution offered is that of the local professionals to conducting the exam and relaying the findings remotely to the specialist. But in conditions or situations like this where you really want to assess the patient to create a surgical plan, an examination by the specialist is necessary because that specialist who will be performing the surgery can, in more detail, counsel the patient and get other members of the healthcare team involved where they may not even had thought of it in a virtual meeting. The treatment of gynecological malignancies with telemedicine modalities have also been evaluated. Now, this particularly speaks to supervised chemotherapy and administration by local practitioners with the support of the remote oncologists. And the initiation of this practice and the administration of drugs is really comparable, but the studies are young. More research is needed in this area. Surgical management is more complex, with studies considering remote robotic surgery or simply telementoring of the local surgeons. But telemedicine may help to provide continuity of care with specialists for patients with surgical complications and present to the local hospital. So if a patient had surgery done by the specialist in the urban area and then have gone back home, they develop a complication, they don't necessarily have to come back to the urban area. They can go to their local institution, and through telemedicine, the doctor on site can be advised as what is a likely problem and how to address it. Now, telemedicine in Jamaica. During the COVID-19 pandemic was a perfect opportunity to assess the uptake of telemedicine in Jamaica. And numerous protocols were initiated by the Jamaican government in monitoring patients with COVID-19 remotely in an effort to reduce exposure to the population of persons who did not have COVID-19. A study that was done here, conducted by the Northern Caribbean University, entitled An Assessment of Jamaicans' Use of Telemedicine During the Coronavirus Pandemic in 2021, had concluded that telemedicine affects patient satisfaction and engagement. Conclusive evidence reveals that most Jamaicans do not utilize telemedicine software. They prefer face-to-face patient care while being cognizant that telemedicine can be moderately effective and is a safe way to maintain social distance. Now, this is a matter of change. People do not like change, hence the low uptake. The same study went on to state that there is little doubt that the use of telemedicine is effective. However, the transition to a world where telemedicine is employed to the maximum will not be realized if governments and healthcare organizations do not produce strategies to encourage its development. Essentially, this is a summary slide. The application of telemedicine in obstetrics and gynecology. The telemedicine modalities, synchronous to detect fetal abnormalities, and also to optimize medical disorders in pregnancy and to discuss treatment plans. In gynecology, as we said before, medical abortion clinics, gynecology, and also low-risk gynecology conditions. Asynchronous, digital imaging, so histopathology specimens, remote video clips, etc. can be accessed by the tertiary institution to further guide or dictate patient management. Remote patient monitoring, fetal movements, weight, heart rate, blood pressures, and also bladder diaries under gynecology. And for mobile healthcare, patient reminders and reminders of patient appointments, breastfeeding tips, and also apps for incontinence exercises and reminders via text messaging for contraceptive use. Now, telemedicine for the future. There are many benefits to telemedicine, as have been discussed in the past. 20 minutes. However, there are challenges. And in our low middle income setting or third world country, there are significant financial costs. To develop a telemedicine infrastructure, we would need equipment. There are equipment requirements to ensure secure and high-speed transfer facilities. So we want the best pixels in the camera. We want to view the images clearly to make informed decisions. There would have to be research and site resource assessment, because not every site would be able to maintain that type of facility. For example, if a site is located in a lightning zone, the towers are consistently hit by lightning, consistently having to be changed out, and they're not working more than how they're working. Also, there are ethical and medical legal considerations. There's an ethical framework, patient confidentiality. As the first presenter had mentioned, there's serious problems with maintaining patient privacy. So we have to ensure that. Also, a regulatory framework would be needed. Medical acts, professional indemnity, information governance. Where is the information stored? How is the information inputted? A record of who inputs the information, and also clinical governance that would be needed. And ending, in telemedicine for the future, it can play a significant role in education and training. Currently at the university, or a couple years ago, there would be a main lecture theater where the lecturer is presenting and presents. And then there would be a secondary theater where the presentation is projected on a screen. And from there, transition to having patients, medical students, all the way in Montego Bay in their preclinical years being a part of the medical school. So they would not have to come up to Kingston until year 3. So certainly telemedicine has been around. It is being used successfully, but there are shortfalls and there are challenges, and it has potential to really blossom into something wonderful in the future. And with this, I say thank you. Thank you all for listening to my presentation. I wish you all a wonderful rest of the day. Are there any questions?
Thank you, Dr. Brown. Are there any questions for Dr. Brown from our attendees? Let me see. Colleagues, questions for Dr. Brown? And I'm seeing no questions in the chat. So thank you, Dr. Brown, for your presentation on telemedicine in obstetrics and gynecology. Thank you, sir.
Thank you. You're welcome.
At this time, we're going to be inviting Ms. Doreen Cushney, Director of Nursing, Department of Obstetrics and Gynecology, to present to us digital midwifery and digital midwife.
Morning. Video.
Ms. Cushney?
Hello, hi, morning.
Morning, my dear.
Are you hearing me?
We are hearing you.
Okay, and you're seeing me too?
Yes, hi.
Okay, sharing my screen.
Please go right ahead.
All right, you're seeing my screen?
Yes, I am. You want to put it in slideshow?
Am I there now?
Perfect.
All right, great. All right, thank you so much, Mrs. Stakers-Reeves, and good morning to my fellow panelists and to all the attendees on this webinar this morning. And it is my absolute delight and pleasure to have been asked to make this presentation. And as I said to the organizer, it caused me to, it opened my eyes to, you know, what is going on out there. Because when she spoke about, you know, the digital era and healthcare, and she said something to do with midwifery. And when I started to research about the digital midwife and so on, I said, wow, interesting. And so it was really an interesting moment preparing this. And it is also my pleasure to follow after my friend and colleague, Xavier, and Dr. Kimmery. So this is really a nice segue after Dr. Brown's presentation to speak about digital midwifery and the digital midwife. All right, so in a way of introduction, digital technologies are increasingly affecting nursing and midwifery globally. And examples include the growing presence of artificial intelligence, we commonly refer to as AI, and robotic systems. Society's reliance on mobile, internet, and social media, and the increasing dependence on telehealth and other virtual models of care, particularly in response to the COVID-19 pandemic. And we did see much of that at the University Hospital of the West Indies during COVID, when we had to have our patients isolated and, you know, reduce the amount of time that we spent in the rooms, and the cell phone became such a wonderful tool at that point in time, when we would give the patients a cell phone number that they could call the nurse, and the nurse could call them without actually go into the room. So we did see that coming out of the pandemic. So in March 2021, the Royal College of Midwives, so this is in the UK, launched a position statement calling for every trust in the country to recruit or train digital midwives. So digital midwifery has not been around for a long time. So, my research tells me, like in about the last 5 years, that this has become a thing. And so that happened in 2021. And shortly thereafter, in the same month, the NHS also launched a new national digital midwife role. All right, increasingly, midwives are using digital technology in place of handheld equipment, handheld records to record and document midwifery care across the continuum of care. Digitizing maternity services is transforming the way midwives work, and digital midwives are leading this change where digital midwifery is concerned. As part of the maternity transformation program, digital midwives use their clinical expertise to streamline traditional midwifery processes and provide digital solutions for safer and more personalized care. And we heard Dr. Brown speaking about how we would be able to interface with patients from where they are without them coming into our offices. So who is a midwife? A midwife is a type of healthcare provider that cares for a person throughout pregnancy, labor, birth, and the postpartum period. And I must interject here that we do have some male midwives, because the name says midwife, but they're probably mid-husbands. All right. So like a physician, a midwife attends labor and delivery to safely bring a newborn into the world, and to ensure that the mother also is safe. In low-risk pregnancies, a midwife can autonomously deliver in a hospital, birthing center or in the family's home. In Jamaica, we are not seeing so much of the deliveries in the family's home anymore. But this in the past, and some persons on this webinar may even have known district midwife who practiced out there and delivered a number of babies, right? If I'm not mistaken, I was one of those who was delivered at home by a district midwife. All right, so all the midwives out there, we just want to thank you for being an awesome midwife. The digital midwife now, she is I'm not gonna say she, I'm sorry, is an experienced midwife with enhanced knowledge of digital issues and information technology systems within maternity care. So this person would have had significant experience in the practice of midwifery clinically, and so knows quite a bit of what and how midwifery practices go. The digital midwife focuses specifically on delivering digital maternity transformation. So there is digital nursing, but the digital midwife speaks directly to this person who is focused on maternity care. The digital midwife is also a subject matter expert and a recognized digital leader. The digital midwife will ensure clinical practice supported by digital technology meets professional standards, because that is quite critical. So here we see the midwife with gadgets in hand. All right, roles and functions of the digital midwife. This person will lead the digital maternity agenda, promoting changes in the profession. And one of the persons I came across when I was doing my research is a midwife called Misbah Mahmood. And this person is a digital midwife at the Leeds Teaching Hospital at the NHS Trust in England, in the UK. And she was the first person who they recruited in a temporary position for 6 months, you know, when they're bringing her on this new initiative. But then since then, she has gone on to lead the charge in the area of digital midwifery. So the digital midwife uses digital technology to improve service delivery, improve women's experience, and improve quality and safety of care. The digital midwife will also work closely with staff across multidisciplinary teams to support effective working relationships. And our first presenter, Ms. Brown, had spoke about not working in silos. And this is critical because you cannot operate on your own when it comes to the digital area of healthcare. It has a lot of multidisciplinary inclusion. The digital midwife will also provide support to those who find technology challenging. And there are several of us, myself included, who do claim some challenges with the technology, getting there, learning, but so this person or these persons who operate as digital midwives will have the expertise to be able to guide persons in accepting and adapting to this new technology. Also, they provide support. They support data collection by ensuring that staff are effectively using electronic systems to capture key data. So we will know that each month there are specific data that is collected in order to make presentations or in order to input into health record systems, because that is the way how we are going to be able to monitor our health services. We are going to how to improve, what do we need to change, and so on. So we'll talk about maternal mortality, infant mortality, perinatal mortality, stuff like that. So all that information would have to be captured using this digital system to get all of this information. So this digital midwife will see to it that the staff are collecting the appropriate data that we use. and that will become needed. The digital midwife will also evaluate data quality in order to support local and national data collection. So it is not just an in-house operation, because this is going to facilitate how the health system, maternity health system, operates nationally. Some core competencies of the digital midwife: must have a good range of experience in all aspects of maternity care, and I spoke to that earlier. Have a good understanding of leadership and change management, and this cannot be overemphasized, because it takes a lot getting used to, and as Xavier mentioned, change does not come easily. And I am experiencing that now, because at our hospital, the health information management system is being implemented, and it has been taking years. It has just come to my department, just on the gynae ward at this point, still not on the obstetric area, but there are so many challenges. And so we have to know, in order to understand, in order to be able to manage this change, the digital midwife has to have a good understanding of leadership and change management. Good knowledge of any developments or changes in clinical best practice. So you have to keep up to date with what is happening out there, so that you can make the necessary changes to our situation to implement anything that's happening out there that would improve our practices. Good knowledge of which data is regularly collected. You must also have that knowledge. And I spoke to that earlier when we said the key performance indicators that will be necessary to assess our maternity services. So this person will need to know what data is regularly collected and needed by the hospital or the agency they work with in the first place, and then nationally, because this information will have to be passed on. A good understanding of how the health, or the maternity in particular, system functions. Other competencies: this person does not require specific IT skills, but enhanced knowledge of digital systems and processes is a plus. And one of the things that is critical to for this person to have is the name has just slipped me, right? Excel, knowledge of Excel, because a lot of the data will be inputted in that format to be shared and so on. So although not requiring specific training, but the person must have good knowledge of these systems and how they work. Also, a good knowledge of existing literature surrounding the benefits of digital working and effective digital transformation. So you can't just know what is happening in Jamaica, or what is happening in Kingston, or what is happening in University Hospital, as the case may be, or, you know, as that's where I'm from, but you must know what's going on globally. What are the benefits of digital midwifery? Patients' expectations of managing their own health is growing with the introduction of remote monitoring and virtual wards. And we see where you can be in a room somewhere, and you can start your car before you get to your car. You can monitor your home from your cell phone wherever you are, things like that. So people are utilizing these kind of facilities more and more, these kind of technologies. And so it is no different with managing their own health. They want to be able to go on their own devices, pull up their medical records, see, you know, what happened at their last visit, that sort of thing, be able to make contact with us, and so on. So those expectations in healthcare is changing, and so we have to change with that. So digital midwifery makes it easier for the transfer of care to another provider, because our records will be digital. So there's a patient in a rural setting who needs to be transferred to a tertiary institution such as VJH or KPH. And so the records are digital. So rather than having to go write up these referral forms and write a long summary of the history of this patient, the digital records can easily be a click away. You click on it and you send it to the area where you're referring the patient to. So it makes it so much easier. It enables self-referrals. So you have the technologies and you have particular apps on the devices. So the patient believes something is going wrong, they're not feeling their usual self, they're not happy with what is going on, they are able to refer themselves, like to a emergency room in the case of what happens in the UK. For us, our patients are able to come directly to our labor ward, but in some jurisdictions, they have to get appointments and so on. So when they're able to self-refer, they have information at their fingertips that they can pass on to the area where they're trying to get an appointment. And so it will enable them, based on what they pass on to the institution, for their appointment to be expedited. And we know where patients are able to get quicker care, the pregnancy outcomes are much improved. All right. Another critical thing, the benefit of digital midwifery, is that it supports the audit and risk management processes. And that is something which is very critical for any healthcare organization, because risk management is something that is paid close attention to. And if the information is readily available digitally, rather than, I know what happens, though, you have to pull the docket. Sometimes you can't find the docket. Sometimes the docket may have been damaged. Somebody may have borrowed the docket to do a study, to do a research, to do something, or it has been misplaced and you can't find it. Hopefully, if it is digital, they'll be able to pull it up quickly, and so this supports any investigations or any, that may need to be done. One way midwives use technologies through electronic health records that Ms. Brown spoke to earlier. And these contain patients' medical histories, diagnoses, medication. She spoke to allergies and so on. So all of these are in one centralized location. You may know sometimes a patient comes to clinic, the docket is there, but the patient did a particular investigation. The physical paper hasn't come back with that result. Whereas if it was digital, information was digital, then the healthcare provider could now go on that system, get into whatever application and pull up that result. So it's right there at your fingertips without having to say that, have the patient go sit and wait until somebody can physically go and retrieve this result. With electronic health records, midwives have a comprehensive view of a patient's health and can provide higher quality, coordinated care, because it's all there in front of you. It also facilitates online collaboration between midwives and physicians. So we spoke about our low risk patients who the midwives can see without a physician being present and so on. But sometimes something may have cropped up or the midwife is concerned about something. It is easy now for the midwife to reach out to a physician such as Dr. Brown and say who is on the team but not present, and pass on something digitally to say, look at this, the patient has come back with this result, an ultrasound or something. Give me your feedback, your information, what do I need to do if that is outside of the midwife's remit. So there's one platform called Alertive, where midwives are able to discuss complex cases, get second opinions, and coordinate care plans. All right. And this kind of interprofessional collaboration really helps us to have better outcomes for our women. Midwives are also turning to remote patient monitoring, referred to as RPM tools. And so like wireless devices, mobile apps to monitor patients outside of the care facilities. So the patients will have these devices with them, or they'll have these apps on their mobile devices. And they can feed that information to the caregiver, to the midwife. While technology cannot replace the human touch that midwives provide, digital solutions will help to enhance our practice. So we know that nothing replaces that human touch. But so what we want to do is enhance our practice. So by leveraging the health records and the remote equipment that we use, online collaboration tools, etc., midwives worldwide are able to deliver safer, higher quality patient care. The rise of digital midwifery promises better experiences and improved outcomes for mothers and babies. So I'm looking forward to getting there in Jamaica. All right, so you see the woman here in front of her laptop with her phone in hand, and she is speaking to Jane, her nurse midwife, right? And they are discussing her care and what may be going on. So this, as with everything, there are challenges. And so there are challenges to digitalization, where digital midwifery is confirmed, and with anything else that is being digitalized. So what happens, digital technologies may be viewed as a distraction from or an unwelcome intrusion into the hands-on caring role and therapeutic relationships that midwives have with patients and families. So you're thinking that, oh my God, everything is going, you can't get to see the patients, you can't get to talk to them, you don't feel that connection because they are there, you are here across a digital network. Excuse me. So that is one of the challenges. Another one, this purported incompatibility with traditional midwifery ideals, such as compassionate care, may explain some midwives' reluctance to adopt digital approaches to healthcare. So as I said, change doesn't come easily. Another challenge, slow progress in some areas has been due to a lack of leadership. And we spoke about leadership and change management earlier. And also investment that supports nurses and midwives to champion and lead digital health initiatives. So sometimes the support is just not there. Support, it could be physical support, or, you know, and it could also be financial, where the investment is just not being put in those areas. There's also a huge difference existing among countries and regions of the world in terms of the digitalization of healthcare processes, access to internet connectivity, transparency of health information processes. So these are some of the challenges. Some areas, internet access is so bad, and even right here in City Kingston, sometimes you go up into some, even up to Stony Hill, I go to visit a friend, and when you're up there, it's like you're cut off from the world because the internet connection is so bad. So, and some countries just do not have the resources to put in these facilities and, you know, to start this digitalization. So those are some of the challenges. There are, for anybody who's looking to listening here now and saying, oh, this is interesting, there are various career opportunities in when you enter this field. So it could take you to the level of what we used to call matron, but in our jurisdiction now we now call senior director of nursing. It's still named, it's called matron, like in the UK and so on. You also can become a specialist midwifery. So like a practice educator, so like Nurse Brown this morning, she teaches health informatics. So this, as a midwife, she could become the practice educator for getting persons into training to get into digital midwifery. Governance midwife. So these are the persons who will inform policies and so on. So when you are the digital midwife and you know what's going on, you are able to see how the clinical aspect interface with technology and bring both together to improve our practices. You can help with formulating policies. So you become the governance midwife. You can become the digital lead for your local maternity system. So when the system is being implemented, and so you need somebody to spearhead this specialization, then that could be a role that you fall into. There's also something called a Chief Clinical Information Officer. And you know, you have the information officers in politics, in government, in all the health areas, in different in education, whatever. So these are persons who they are the go-to for specific information, similar to the Chief Midwifery Information Officer. All right. You can become a technology lecturer. We saw that. So what is the way forward? Some key recommendations. Nursing and midwifery must accelerate the transformation to a digitally enabled profession by investing in informatics education, research, and I will also show what I have on here. All right. Nurses should upskill in data science and other digital health topics to enable emerging technologies such as AI are developed appropriately and safely for nursing, midwifery practice, and patient care. So we must have a say in what is being developed for us as nurses and in particular midwives. Nursing and midwifery must invest in and lead digital health developments and collaborate with others to develop and deliver digital tools that patients and the public need. Nurses and midwives should champion informatics across all areas of professional practice, create leadership opportunities in digital health, and inform health policy in this area. So lots of work for us in nursing and midwifery. And this is just a flow chart that points to, that takes you through how digital technology will help. So there's a woman's healthcare event or history, hope you're able to see it. The midwife enters details into the maternity IT system. So this information is available for other healthcare professionals who are working with this patient to see. The data is used in referrals and reports, and that data is also used to populate hospital database, right? So when that information is readily available for other healthcare professionals, it helps to improve communication and information, right? Both for indirect and direct clinical care. When that data is uploaded, it can be, for referrals and reports, external health professionals who are involved in the care have access to it. So that is used in the direct clinical care. This is also used to notify external agencies that are as required by law. So you may have like public health that has, you need to report some class 1 notifiable diseases and so on, other information. So that is there for and readily available. All right, national data collection such as birth notifications and so on, that data is there. And when it is used to populate the hospital database, it's there for research to help change our practice, improve maternity care, so we have better outcomes for our women and improved population health. It's also there available, the data is there for national statistics, for policies, in policy making, and so we can use those statistics to benchmark, to assess where we are and so on. And all of this information also is used to help funding decisions and national targets, and see we come back again to improved population care. All right, and here we spoke about, and here refers to auditing, which we know is critical in order to improve our risk management and to help us with our care. And so this was taken from the Royal College of Midwives site. So in concluding, despite substantial advances to date, challenges in nursing's use of digital technology persist. And we spoke to what some of the challenges were. There is still a perennial concern that nurses and midwives have generally not kept up with rapid changes in digital technologies and their impact on society. So that was something that came out when I researched. All right, and this limits the potential benefits they bring to nursing and midwifery practice and patient care. To respond to these challenges and prepare for the future, nursing and midwifery must begin immediate transformation into a digitally enabled profession that can respond to the complex global challenges facing health systems and society. As I said, lots of work for us to do. And the specialty of nursing informatics has long advocated for the integrated technology to support the profession, but it has comparatively few practitioners globally. So therein lies some of the challenges. So I hope this has opened your eyes and has shed some new information for you, as it did for me, right? And here in 2023, in July, just this year in Sydney, Australia, there was a nursing and midwifery digital health conference. And so we are getting there, maybe slowly, but surely, and I don't think there's any turning back. So thank you so much. These are my references. And if there are any questions, I'll take them at this time. Thank you.
Thank you, Lady Kushney. A very concise and informative session. Now, I looked at our question and answer chat, and either you or Dr. Brown or Nurse Brown can answer any of the two questions I'm about to pose to you. And the first question was, someone was asking if the patient information that is found on the digital platforms, if they can be used without permission in terms of observing trends or used for statistics. As you know, we're moving into the research and digital age. That's the first question. So any one of the three presenters can answer that question. Anyone want to take that one? You want to take one, Ms. Cushioning, or?
Could you repeat that first part, if anyone can what?
The use of the information, the patient data that is placed on the system, if it can be used without patient informed permission from the patient to look at trends and to look at statistics, use for statistics.
Okay, well, I think maybe Kimmery did speak to different levels of access where persons are able to access only specific information on some of these platforms, right? So and she could jump in at any time as well as Dr. Brown to say that there are going to be specific restrictions. So there would have to be some other level where you can go and access that information. It couldn't be that just everyone is accessing every information that is there. There would have to be specific access, and that would have to be worked out because, as you say, we are research led, and as a research institution, a lot of the information is going to be required. So there will have to be particular what you call it now, in place. They'd have to protocols in place as to how people access this information.
All right, so the second question is consent for sharing information. So you spoke about in digital midwifery where a patient would be referred to, say, a Victoria Jubilee or so forth. The question is there going to be consent for sharing these information between the different institutions?
Well, as it exists now, when patients need to be referred, the patient is informed. And a part of this referral, the receiving agency must get information about the patient. So formally, it would have been in written form. So it will be something that is written and the patient takes in. It's just a different way of sending it. So I am not sure that there will need to be any, say, assigned consent from the patient to share our information. I'm not so sure. Don't know if Kimmery can speak to that, but as I say, it's just one other way of sharing the information that would have been shared in a hard copy anyway.
Okay. Are there any other questions from our panel attendees? I don't see any more in our...
No, not seeing anymore.
Right. Thank you, Lady Kushney, for a very concise and informative presentation.
You're welcome. Thank you.
At this time, we're going to move on to the use of AI robots in surgery, and this will be presented by Dr. Lincoln Cox, consultant surgeon, general surgery, Savlamar Hospital. Is Dr. Cox on? Dr. Cox? Are we seeing Dr. Cox on?
Dr. Cox is on. Not sure if Dr. Cox is by the PC at the moment. Trying to get Dr. Cox to unmute.
Yes. Sorry, guys, I'm on. Are you hearing me now, guys?
Yes, we
Yeah,
are.
loud and clear. Can you start your camera as well?
Okay.
Our attendees would love to see you and
Yes, please.
Okay.
wonderful.
All right.
All right, wonderful. So let's go
let's
ahead
share
and
this.
share your screen.
You're welcome. Could you change that to your site? Okay, awesome. Thank you.
Okay. All right. Well, first I want to thank the Jamaica Association of Nursing and Anesthetists for inviting me here. It's a pleasure to present from Sablamar in Jamaica on such a topic. I think this symposium is targeted somewhat at us because we're in a remote location, and I suppose things like electronic medical records and telemedicine and so on is applicable to people in remote areas. I've listened to some of the challenges that would have with that, and we do have it here in terms of accessibility to the internet and so on. But I'm happy to present this because this is something that most of us have thought about, whether directly or indirectly, in terms of artificial intelligence, even if it is through our watching movies, just looking at things like the Terminator and so on, and Star Trek. So I want to approach this basically from more like a historic point of view in terms of surgery and how surgery has evolved with machines. The picture on your screen will depict a very brutal way long time ago. This was probably before the 18th century, where breast tumors were just basically clipped off with a large pliers of sorts. More than likely in the era without anesthesia and without any form of antiseptic or antibiotics. If we look at surgical instruments has also evolved, and this is where one of the aspects of things that we'll be looking at in terms of AI. A picture of a very old wooden surgical table. But let us look before to say that before the surgical table, there were surgical chairs. The earliest forms of surgery was related to perhaps the Egyptians, and in some literature, the Romans, who were treating medical urinary tract obstructions and had developed a series of instruments to detect, to remove stones, because it was a very painful process when patients had bladder stones and had acute urinary retention. In those days, there were no anesthesia again, but surgery advanced with the evolution of anesthesia, the use of ether in 1876 in Boston. And before that, most patients were given alcohol and opium to try and blunt their pain receptors. In the 1920s, Alexander Fleming discovered penicillin by accident and became commercially useful in the 1940s. However, before him, Joseph Lister had used antisepsis, which basically used the chemical phenol to soak gauze and to wash the environment for surgery. The development of anesthesia allowed for good perioperative management of surgical incisions and decreased mortality and morbidity. Jumping quickly now to the ability to have open surgery, the ability to enter the coelomic cavities, and things like laparotomy, thoracotomy, and craniotomy became possible with the advent of anesthesia, analgesics, and antibiotics. So open surgery of the abdomen and thorax were now possible. And as surgeons thinking about trauma to patients evolved, the concept of minimal invasive surgery was born. It is well known that open surgery and tissue damage, use of instruments, can have deleterious effects on the outcome of the patients and cause excessive trauma where it's not necessary. So minimal invasive surgery was envisioned. Now, what is it? Well, one of the things that we use today in general practice, and certainly at Savlamar Hospital, is the use of laparoscopic surgery. It's one type of minimal invasive surgery. And it says, instead of making a big incision, there are small cuts that are made that tend to preserve the intracoelomic environment, natural environment, and hence help to speed recovery. Laparoscopic surgery certainly is practiced here in the Savlamar Hospital. We do laparoscopic cholecystectomies, laparoscopic colectomies, laparoscopic appendectomies, and even laparoscopic repair of perforated duodenal ulcers. Robotics. So fastly, moving on from laparoscopy, where we use our human hands to handle slender or small instruments. The use of the computer to handle these small instruments in a laparoscopic fashion. The ability of the cameras now that develop to have a wider angle of view, increase surgeon precision, dexterity, and their control during surgery. Now, the Da Vinci system is one common or well-known in over 50 countries now, over 100 countries, sorry. And one of the drawbacks to this, of course, in a third world setting is cost. So robotic colorectal surgery, first performed in 2001, of course, in first world countries, and certainly not applicable to Jamaica as yet because of the costs. But if you look at the setup in initial setting was one of a huge amount of equipment. However, these equipments allow for a better platform for stability, accurate incisions, and which cause for greater dexterity and a wider field of view. And most of all, the decrease in the disruption of the natural environment of the cavity that you're entering. So the surgeon will sit at a console and monitor the robot as it performs the operation. Other forms of minimal invasive surgery, natural orifice endoscopic surgery notes through transoral approach, transvaginal or transanal approaches, are other approaches used in surgery, minimal invasive surgery. Now, some time ago, I think it was, look at this saying that Gandhi says, with the introduction of anything new, that first, you might ignore it, then you might laugh at it based on what is proposed. For example, in laparoscopic surgery, when Erling Mew introduced laparoscopic cholecystectomy, I think the first patient he had died at laparoscopic surgery, and Erling Mew was sent to prison because minimal invasive surgery then was unknown to most surgeons, medical personnel, and hence at a jury that of his peers, he was found guilty of malpractice and was sent to prison. However, not to ignore Mew, because now laparoscopic surgery is one of the cornerstones of surgery. So first you may ignore it, and then you might laugh at it, and then you might fight it as he went to prison, and then laparoscopic surgery win. No, it's been said about revolutionary ideas and movements. And so this is also something that may be true when we now introduce artificial intelligence, as artificial intelligence looks at how, more importantly, computers and robots now make decisions about important matters at surgery. So in 1942, Isaac Asimov, a visionary, he was a biochemist, a professor of biochemistry in the US, his cognitive processes were racing with thoughts of robotics, and just looking at its potential, he came up first with the laws of robotics in order to protect human beings. So quickly, the laws. So that robot may not injure a human, must obey the orders of a human if it not conflict with the first. A robot must protect its own existence as long as such protection does not conflict with the first and the second law. And then a fourth law was added recently with the explosion of social media. That was thought of as a missing fourth law. This was not by Isaac Asimov, but was just added. That a robot must identify itself. So human beings think we now think we have the right to know if we are interacting with a human or artificial intelligence on social media. So what is artificial intelligence then? Well, it may be loosely defined as a study of algorithms that give machines the ability to reason and perform cognitive functions such as problem solving, object and word recognition, and decision making. The critical part is decision making. But decision making comes from human beings creating programs that help machines to quickly analyze huge amounts of data in various ways. And this was previously thought as science fiction, that a computer could not think or make a decision that's appropriate based on what it knows. However, it is here at the 23rd Olympiad in Japan in 2021, we were exposed to automated vehicles. So here we have an automated vehicle in the Olympic Village. It was totally automated. It will stop, it will let you off, you go. There's no driver, nobody monitoring this automated vehicle. In 1956, Professor John McCarthy, who is now thought of as the father of AI, predicated artificial intelligence on the main principle that computers could precisely, he thought that, listen, computers could precisely mimic cognitive function of human being, such as learning and problem solving. Now, the computational algorithms will learn and improve with experience. These improvements are becoming more popular. Deep learning and artificial neural networks became cornerstones of significant achievements in image processing. And as a result, brought us to this concept now, or this hugely blossoming era of artificial intelligence. Is the computer more versatile, or will outlast, or will become an existential threat to human beings? From a long time, there's always a rivalry between computers and man. John Henry, this is a folklore about the steam engine and he breaking rocks, competing with the steam engine, and eventually died. However, in real time, we have machines like Deep Blue that plays chess, for example, against human beings with mixed results. Now, machines came to fore about the time of the Industrial Revolution, where we stopped doing a lot of things by hand, and the machines started to do these things sometime between the 1760s and 1840s. This caused a massive shift in productivity and what we think is an increase in the quality of our lives. So AI, artificial intelligence, we are at all with it because it increases productivity and a questionable never increase in the quality of our lives. And then there's awe and there's fear and trepidation that artificial intelligence may outperform us and outthink us, outthink its creators, which are the human beings. So let's just look a little further and dive a little deeper into artificial intelligence. What is the core tenets of artificial intelligence? The 4 core tenets here for computers and machines is the ability to have machine learning far faster, far more complex ways of learning than human beings. 2, natural language processing, the ability of the computer now, not only to learn a new language, but also to understand based on history, innuendos, mistakes made by human beings, and also correct those in the aim of understanding processes. The development of artificial neural networks, and then the use of computer vision, which we see every day in terms of computers in radiological investigations that help to analyze the anatomy. So let's look at machine learning. So machine learning enables machines to learn and make predictions by recognizing patterns. So computers now can, the first talk today was on emergency medical records and emergency health records, digitizing those records and having them available. So when a machine could grab all that data and analyze it in a very short time. So machine learning allows a computer to utilize something called partial labeling of the data, which is supervised learning, or just to identify or detect structure within the data itself. And this is the scary part, unsupervised learning. So the machine itself will sit there and look at the data and almost like a jigsaw puzzle, tend to make sense of things that seem to go in different directions. Mistake made by the clinician, misspelling of words, and etc. So the third category of machine learning is what we call reinforced learning, and something that we do as human beings. And this is how we learn to drive like a motor car or infer medical decisions based on history. And but we do those things while learning when we make a mistake and what are the things that make us successful at doing those things. Now, this is one form of what we call operant learning. And we learn and our behaviors change based on the outcomes that we get. And machines are incorporating this kind of reinforcement learning in the analysis of data. Machine learning is particularly used for identifying subtle patterns in large data sets. Now, these patterns might be imperceptible to human beings, and they employ complex nonlinear relationships and multivariate effects than conventional statistical analysis. So we might not be able to process data sets with 4 or 5 different ways of doing it at the same time, but machines can. Now, there are some examples here where the machine learning has outperformed. There's a logistic regression model for predicting surgical site infections. And we do it manually by building nonlinear models that incorporate multiple data sources, which include diagnosis and laboratory values. But the machines are now able to predict surgical site infections at a faster rate and more accurate than human beings can. This data is not very well placed here. But if we look at international classification of diseases, in terms of identifying surgical patients with lung cancer staging by using ICD claims, the machine was able to be more sensitive, 93% sensitivity, 92% specificity, and 93% accuracy, as compared to human regression processes that had 53% sensitivity, 89% specificity, and 72% accuracy. So the computer was a lot more accurate and more precise. What about language processing, the second tenet that this is based on? Now, the computer's ability to understand human language is crucial for large-scale analysis of contents. Now, we can have data, emergency medical records from various countries in various languages, but the ability of the computer to understand the language without it being taught makes it easy for the computer to put these data sets together and make relevant inferences based on the data that's there. Now, a lot of the incorporation of little things like syntax errors and errors in writing or typing, a human level understanding of the language makes these errors, but computers can correct them and then end up with the more correct inference. Not going to look at this too much because it's a little bit too wordy. But the third level of computer understanding that makes artificial intelligence very attractive to all processes and in surgery is the ability of computers to have neural network processes with layers of almost mimicking the levels of interneuron connections in the brain, where machines can learn from each other. And once there's a connection between the machines via the internet or information being fed into the machine from other sources, then it can, on these neural networks, almost behave as one. So one machine don't have to learn the same thing. Don't have to learn everything. So one machine can understand a concept, and once it understands that concept, other machines automatically understand the concept. So if one machine learns how to fly a helicopter, the next one understands it almost immediately and just download that information. And that's what makes it tricky, because even though in the end, we're going to realize that when we start applying these concepts to clinical practice, right now it seems almost impossible. But as Gandhi says, don't laugh at it, because we may have to fight it. and then it might, who knows who will win. Now, one model of looking at artificial neural networks and capabilities in terms of sensitivity, in terms of analyzing risk prediction for patients with pancreatitis. We find that the Apache 2 sensitivity was much less than the artificial neural network's ability to be more specific, 96% versus 85%, and 89% versus 80%. Now, the last tenet is really the ability of computer vision. Really the machine's ability to understand images and videos. So a machine can, it is thought that the machine, as we said, can, once one machine analyze a video of a surgeon performing a laparoscopic cholecystectomy, for example, it can analyze vast amount of that data and not only correct what it sees in one version of the video, but through an amalgamation of many videos and images, produce the perfect video or the perfect algorithm that will allow it to approach laparoscopic cholecystectomy, as one example, in a perfect way. And because of the ability of computers to do this through machine learning, understanding language, and then artificial neural networks, then it is seen that this explosion in understanding the machine, in making a decision now, would make the machine more superior in terms of going about doing analyzing a patient, analyzing the risk factors associated with surgery, decide whether or not surgery can be done with certain outcome, and provide more information to the patient. Now what about synergy and the ability of AI and other fields to communicate? Now, most of the promise of AI lies in its applications that combine aspects of its subfields, right, with other elements of computing, such as database management and signal processing. It is analogous to mobile phones in the unit accessing information from one central point, and cloud computing, the ability to have different handheld devices, but downloading information from a continuous flow through a central point. Now, advances in both hardware and software does affect each other, vice versa. So even if the software improves, but we can't find material to make instruments more mobile or flexible, then it would have created a hindrance to the advancement of artificial intelligence in surgery. So clinical application of such work include the successful utilization of deep learning, where one, for example, if you use in experiments that uses mobile phones to look at pictures to determine the difference between benign and malignant skin conditions and the accuracy levels, it has been found that the computer vision algorithm for this classification is more accurate than an equivalent to a dermatologist who will look at the same images and make a prediction. And this was a study done by the dermatologists in classifying skin cancers with deep neural networks and human classification. Another study looked at the prediction of anastomotic leaks analyzed by the computer through AI's ability to analyze large amounts of data and to interconnect at different levels with the artificial neural networks. And they found that their accuracy of determining or predicting a leak was more, where the accuracy rate was higher than for individuals making that prediction. However, though the computer in theory can come up with more accurate ways of, or reading an algorithm, or having more information at hand at the time to make a decision, translating that into practical work. For example, the smart tissue autonomous robot was designed to, in a simple way, to see if a robot could suture an incision that was made more accurately, with better dexterity and so on, than a human being, or over longer periods of time, simple things like making a knot at surgery. And it has been found that the robots cannot match human dexterity in real life in terms of making simple things like doing simple things like suturing and making a knot. So what are the limitations of MI then? We have to be careful with MI because there's a lot of media hype. The media hype creates a lot of disillusionment and fear. If we look at CNN in the last 2 or 3 months, it's always a headline on the existential threat of AI to human beings. So, and with any scientific endeavor, as this is saying here, whatever AI does hinges on whether the correct scientific question is being asked at the time and whether one has the appropriate data to answer that question. So what about our data sets? What about our electronic medical records that we have set up in order for AI to make the proper algorithms and make the proper decisions? Those information has to be correct. Even though we know that with learning, AI sometimes would correct the mistakes made by human beings in data entry. And there's a limitation of AI with cost. And then it's risk of how we utilize machine learning. So this is saying what we said before, outputs of machine learning and AI analysis is limited by the types and accuracy of the available data. So there can be systemic bias within data, chronic systemic bias over time. And these can affect, in other words, biases in electronic or data related to women, a gender bias, or biases in relation to data that's inherent, that is related to minorities due to long-standing underrepresentation in clinical trial and patient registry populations. So a lot of these biases in current data sets can affect how AI, their true outcome or what they're precisely able to do. So what are the, in essence then, what does AI offer, or what is its implication for the surgeons? Well, we know that it can right now augment human performance. How? In some ways, like in this study, where pathologists utilize AI and they have found that it decreased their error rate in recognizing cancer-positive lymph nodes from 3.4% to 0.5% in breast surgery. Now, this will definitely change management of all those patients who were missed before. And now chemotherapy now would have to be changed in order to manage an upstaged breast cancer patient. So in terms of its giving information, in terms of accuracy, it can help. Now, because of this ability to to analyze large data sets and to be more accurate in missing information once it's there. So human beings might skip certain things or not see certain things, but then AI could pick up high-risk patients or risk-stratified patients a little bit more accurately on a continuous basis than perhaps a human being analyzing large data sets. So we can reduce the rates of lumpectomy by 30% in patients who need breast needle biopsies are considered high-risk lesions, but ultimately found to be benign after surgical excision. So in this regard, AI and machine learning help us to decrease the morbidity in patients who are stratified, who are re-stratified by AI technology. Again, implications in patients who may be going any kind of surgery, but to this bariatric surgery, be able to track a patient in terms of weight loss, glucose, meals, activities through mobile applications, fitness trackers with data feed into the emergency medical record can help the bariatric surgeon to decide on the type of bariatric surgery that he's going to perform based on the person's activity and based on their trends, their medical trends over a period of time. So what's the surgeon's role then? So we have implications for the surgeon. What's the role? Certainly we know that for its implication, AI can produce data that benefit or improve the ability of the surgeon to make a decision. Now, if AI is going to, based on its accuracy, can be able to save up over between 300 billion and 400 billion annually in the US alone. So there's great economic incentive to incorporate AI and big data into multiple elements of our healthcare system, at least at that level, to save us money. Now, how can the surgeon add to this? By accuracy in creating registries at a local, national, or even international level. So be more precise in terms of data input and data recording. Now, there are data cleaning techniques that are there already, and AI stand to improve those data cleaning techniques. So these could become linked to increasing the availability of clinical genomic, proteomic, radiographic, and pathologic data. So in AI analyzing emergency, the medical records, in helping to employ techniques of cleaning in order to make the data more pure, then it can improve our ability to make decisions at surgery. So in conclusion then, though artificial intelligence, through its ability to analyze and interpret data and to learn from any unit of the computer, though the true potential then of AI remains to be seen, but we know that it has benefits to us. Its true potential is difficult to predict at this time. We know, though, that artificial intelligence is expanding its footprint in clinical systems, and we talk about databases to intraoperative video analysis, and it can help in analyzing those data. However, the unique nature of surgical practice though, leaves surgeon well positioned to help usher the next phase in by for example, increasing the accuracy of data registries, and to be focused more on generating evidence-based, real-time clinical decision support designed to optimize patient care, and then to help with surgeon workflow. So we're in just looking at the research data, the complexity of surgery is good, or at this point we can say that the evolution of AI, though very helpful to us, is still not ready to replace the surgeon. Thank you very much. Hello, I can't hear anybody.
Doctor, I'm not sure what's happening. Let me see if I can get in touch with someone.
Dr. Cox finished his presentation.
Oh, I'm sorry. Oh, thank you, Dr. Cox. I got a little bit. Okay, thank you, Dr. Cox, for your presentation. At this time, I'm going to be inviting questions from the participants in this webinar. I was checking. Do you see any questions in our dialogue box?
Sure. So the first question from Zoya Mackenzie. I'm trying to apply the MI in reducing risks associated in obstetrics, regarding incision infection or even dystocia, as we have already been assessing the risk levels of our ladies from booking, and this continues throughout care. Not sure. Is that a question?
That's not a question. That's just.
Next question is, why on earth would machines need us after attaining such a superior level of autonomy? Why continue with fragile mankind which gets sick? Dr. Cox, I'm not sure. A bit of sarcasm in that question, but do you think AI is going to supersede mankind and take us over?
Well, that's always been the fear, and that fear has existed since the 1930s, 20s and 30s and 40s. And certainly when I spoke about Isaac Asimov, who saw the potential explosion of robots in all various aspects of human life, and he wasn't necessarily thinking about medicine, but thinking about how humans are going to take over doing our daily activities. And then he said, okay, let us just put laws in place from right now that a robot cannot hurt a human being. So whatever the human being will do to shut down the robot, or then in those laws, the robot cannot, or the intelligence cannot react. However, at that time, Isaac Asimov was armed with very rudimentary knowledge of computers, and not in this realm of artificial intelligence, because it was thought at that time that the ability of computers to make decisions, to actually assess a situation or a surgical patient or whatever the complex situation is, and make an accurate decision as to what it will do, they thought that was way in the realm of science fiction and will never happen. And that's why I put in the presentation when Gandhi said, be careful of what you say, if you laugh at, or what you say can't happen, because it will turn up on your doorstep, and then you have to now start to fight it, but because you didn't think about it then. I see somebody had placed in a group about how, I don't understand how machines can be much more dexterous in suturing in the obstetric field. But if you just know a little bit about laparoscopic surgery and the ability of a laparoscope with an angled laparoscope to turn in various directions, almost like rotating 360 degrees, which if you look at the human eye, it has a visual field that cannot go 360 degrees. We certainly can't turn our heads around like a robot, but you can turn this laparoscope with a 30-degree camera through 360 degrees anytime at very fast rates. And so it can look in various directions at different times very quickly. Something that the eye cannot do. The eye can give you a visual field, but it certainly can't look behind you, for example. A surgeon cannot certainly turn upside down to look at certain things. And so in that respect, with just by the visual fields alone, it gives better dexterity. The instruments now also can be so much angled that it can, the machine, the laparoscope can turn in various directions. And so the human arm, for example, have a certain range of motion that takes you to 180 and that's it, or less than that. But the scope probably could be angled around to various reflex angles that makes dexterity better.
Thank you very much, Dr. Brown. Dr. Cox, apologies. Thank you very much for an informative presentation on robotic. I too myself had some apprehensions, and know that you have made my apprehensions a little bit less. So I hope that persons who are on this webinar, who have listened, who has similar apprehensions, or probably more than I did, will feel a little bit more comforted. Thank you, sir.
Thank you.
At this time, we're going to be moving right along, and we're going to be having Dr. Ronit Goodluck Tyndale, neurosurgeon, neurovascular fellow at the UHWI, pediatric and cerebral neurosurgeon, to present to us advancement in interventional stroke care. I'm looking forward to hearing this presentation. Dr. Ronit Goodluck.
Hi, good afternoon, everyone. Thank you for the opportunity. This, I guess, topic is a little bit different than what we have lined up or what we've heard so far, but hopefully it piques your interest at lunchtime. All right, so let's go straight ahead. So I'm going to talk this afternoon about the advancement in interventional stroke care. And, you know, there's a lot of interest in stroke from every healthcare level. And, you know, I think it's something important for everyone to know what we've been doing in stroke. I have no disclosures, and these are some CDC facts. Now, 1 in 6 deaths related to cardiovascular disease are from strokes. You have a high rate of ischemic strokes affecting mainly the Black Americans, and it is responsible for a significant percentage of long-term disability. What about here at home? In 2022, the Minister of Health and Wellness posted an article just of our stroke epidemic here. More than 7,000 persons have had a stroke event in their lifetime each year, with an annual death rate in Jamaica up to year 2022 of 2,400. That means we've had more than 80 per 100,000 stroke deaths per year. And it is the leading cause of death in Jamaica, with an annual burden of more than 45 billion Jamaican dollars. So, you know, the stroke impact was responsible for, I think, more than 2.42% of our GDP. And today, from a neurosurgeon or neurointervention point of view, we'll be looking at the strokes, mainly the large vessel occlusion. So where the arrow points, you can see that essentially there's a missing dot in between those two white areas, or the middle cerebral artery. And we're talking about intervention mainly for those large vessel occlusions. When we talk about stroke intervention, we're talking about endovascular intervention to remove or quote unquote fish these clots out to restore blood flow and to regain the penumbra that was affected by the area of ischemia. This was birthed out of lower recanalization rates from thrombolysis. So as you know, like things like TPA, etc. And it involves a diverse team of your radiologists, neurosurgeons, your neurologists. And it's become, I mean, stroke care or stroke intervention is standard in most first world, and it's something that we're developing here locally based on the numbers that you've seen in terms of persons affected by strokes in Jamaica. 7% of the patients that you meet with a stroke per year in the ideal setting will be eligible for a thrombectomy, meaning removing that thrombus. Part of our challenge here in Jamaica is access and getting to the hospital on time, even picking up that someone is having a stroke. One of the issue is, our health-seeking habits are not great. So person has symptoms, slurred speech for a day before they present to hospital, and we're trying to increase awareness and some of the try to get or attack some of these problems so that we can improve the stroke care in Jamaica. In terms of the intervention timing, we have looked essentially within the first 4 to 6 hours after the onset of stroke symptoms, the best outcomes are obtained in terms of intervention. However, there are more and more research that shows that even in a delayed fashion, there is utility to offering intervention for large vessel strokes. And the reason why we reached or we evolved or we advanced to the point of intervening to try and remove these clots versus just the intravenous medication that is aimed at thrombolysis, you obtain higher reperfusion rates, lower complications related to hemorrhages compared to the medication, early neurologic recovery, and improved functional outcome. So briefly about thrombectomy. Now, in the 1980s, there was the first attempts in the form of placing these catheters within the vessel of concern and then giving intraarterial medication to thrombolyze the clot. And this has evolved over the last 20 years. And, there was a lot of change where we're now manually trying to remove the clot, and we thought the outcomes were great. In 2013, there were several trials that were long awaited, looking at thrombectomy versus thrombolysis and the outcomes of these patients. And those trials were disappointing. They didn't show that there was any significant outcome or improvement with thrombectomy compared to thrombolysis, but there are many flaws with those studies in terms of their the patient groups that they chose were not ideal. The timing that they were looking at from the onset of symptoms to the time of treatment was much longer than the accepted time, and also some of the equipment that they were using were not ideal. Thankfully, in 2015, we received, good news. There were several trials, your Mr. Clean trial, Escape, Swift, Extend, and your Revascat trial. And all these trials led to grade 1 recommendations that thrombectomy has improved functional outcome and overall much better than thrombolysis only in patients who meet the criteria, meaning large vessel occlusions, your middle cerebral artery, your internal carotid artery, and even extending to your posterior circulation vessels. So when we look at thrombolysis in cerebral infarction, this is essentially a grading system. So where the arrow points here is a middle cerebral artery occlusion. Essentially, if you look, you will see that there's blood flow going into your anterior cerebral artery, but as you get to the middle cerebral artery, as it bifurcates, there is no flow going beyond there. And with thrombectomy, there are several grades. So what has happened in the second angiographic picture is that after a device was passed into the vessel, there has been some flow that has been returned to that vascular branch. and it goes up all the way to Tiki 3, which is what we aim to obtain when we do thrombectomy. So that clot that was here, essentially, now you have restored flow, and there is now revascularization to that entire territory. And that is the aim, to go from a Tiki. I mean, Tiki 0 is not an ideal outcome, but essentially, once the cutoff is seen, then you aim for Tiki 3, Tiki 2B for a good outcome. In terms of where we've gone with the devices that we've used, in 2008, we've used the guide catheters. And if you look at the first device, it's in essential, if you imagine a wine opener. So it's the same approach, where this catheter and the retriever is passed into the clot, and it attempts to engage it and then retrieve it. One of the problems is that because the catheter doesn't go distal or close to the clot, when you pull that clot back, you can actually have fragments that go elsewhere and give you other complications or stroke-related complications. Then in 2016, that technology was improved to a stent. So essentially, the stent is attached to the catheter and it's taken up to the clot, and it enmeshes the clot, and we apply suction to ensure that you kind of, as much as you can, entrain that clot into the stent. You have that, so that when you retrieve the clot, you have you get more vessel patency. Also, placing the stent at the time as well reopens and allows flow in the vessel. And we're now up to our balloon-guided catheter stent retrievers. So in essence, at the end of these catheters, the catheters are no longer only in the proximal ICA, but they're intermediate catheters that go up to the clot. And there is a balloon that you inflate as you retrieve, as the stent goes into the clot. And this ensures that when the clot is being retrieved, that there's no shower of clot that goes proximally. And that is how, over time, the technology has improved, and hence our outcomes have improved. And this is more a demonstration of, sorry, of what I've described. Essentially, this is our old Mercy stent retrieval, where you have that corkscrew type of like a wine opener device. And now we're more to the stent retriever, where the stent sort of enmeshes the clot, and then we retrieve the clot. And here's another pictorial, and this I think makes it even more simpler. So before, the catheter was in the internal carotid, and then you have the stent that goes all the way up to the clot. But now there are larger intermediate catheters that goes all the way up to the clot, to ensure that when you retract the stent, it goes into this intermediate device and then comes down. So less shower, less thrombus that goes elsewhere, compared to the older model, where you have to put this back into the proximal guide catheter, and there all little fragments can come off anywhere along that path. So over time, essentially, if you look on the left, our Tiki 3 rates, meaning full recanalization, has improved as the devices have improved. And over time, the studies as well have shown that these improvement in our toys have improved our outcome. Where we're at now with stroke intervention, now patients who qualify for thrombectomy should be within the period of 6 hours from the onset of symptoms. Their pre-stroke MRS score, so the modified ranking score, essentially describes a patient's mobility or functionality. So in essence, good function in patients prior to the stroke, a large vessel occlusion, older than age 18, your NIHSS score, which I'll show you it's a long list that we go through to see what range the patients are, and patients who are over 6, and aspect which are radiological scoring system greater than 6, that tells you essentially you don't want to do a thrombectomy in a patient who has an established stroke. So you want to, because you want to be able to save penumbra. If they've already had infarcted brain, then your area of your reperfusion or achieving with thrombectomy is not so great. There are evolving studies that essentially will take us to the point of offering everyone thrombectomy, but currently the standard is aspect score greater than 6. Ideally, patients should be symptoms within 6 hours. As you see here, within 6 to 24 hours, we'll talk about that a little later. And there are the dawn and diffuse trials that are telling us maybe we should push the envelope even more. So this is just a picture of what the NIHSS score looks like. Essentially, patients who have low scores have great 30% can have poor outcomes. So essentially, when the patient comes to A&E, you have a stroke nurse or even the emergency room, they quickly do a NIHSS score, and that helps to guide us, whether the neurologists, neurosurgeons, on whether we think this patient is a candidate for thrombectomy. And this is our aspect score. So essentially, the team, the neurology team, the stroke team in Alberta, they looked at the CT score, essentially looking in these listed 10 areas. And what they've done is given a number to all of the different territories for the middle cerebral artery, the ACAs. And if there is an area of established infarct on CT, then the patient loses a point. So if you have symptomatically, you have features to suggest a left MCA stroke, but your CT looks completely normal, then that is good. The higher aspect, the better you are in terms of having a good outcome or being a candidate for thrombectomy. The posterior circulation, there's also an aspect score for that, essentially the same thing, looking at different areas within the posterior circulation. One of the main things with stroke intervention is timing. I think level 1 evidence is for between the 4 to 5 hours, 4 to 6 hours, sorry. Then you have the dawn and diffuse trial, also level 1, suggesting that up to 16 hours to attempt thrombectomy, and your dawn level 2 for greater than 24 hours. So essentially, again, pushing the timing for which you can offer thrombectomy. What about the timing? Just a little bit more. So the early time is ideally less than 6 hours. Initially, the Hermes collaboration suggested that there was no additional benefit after 7 hours, but further studies have more or less contradicted this. So your Mr. Clean trial, your Swift Prime trial, all these trials essentially prove that there was a benefit to thrombectomy for patients who presented with a stroke within 6 hours. So essentially, these patients often still got TPA, went immediately to, so when a stroke code is called, the emergency, it starts from the ambulance calls into the emergency room, says we have a stroke case that is coming, and A&E prepares. Once the patient reaches within an hour, the patient, it should be door to TPA, meaning they come to A&E, they get their vitals done, risk assessment, they're on the CT table. At the time of CT, once an aspect is done, the patient gets TPA. Anyone who's trained to give TPA, doesn't have to be a neurologist, can be a stroke nurse, neurosurgeon, anyone that has had training to deal with acute stroke. If it is that there is a suspicion that is a large vessel occlusion, the patient gets a CT angiogram on the table. So all of this is happening in the CT room. So whoever is in CT, the CT room is stopped. The stroke patient goes as the next patient on the table. TPA is given, CT angiogram is done. If there's a large vessel occlusion, the neurosurgeons get involved, or the interventional neuroradiologists, or the stroke interventionists, and we get the patient down to the IR lab to get the thrombus out. All right, so our delayed time window. So the Revasca trial, they pushed the window to 8 hours. Then the ESCAPE trial pushed it to 12 hours. And these studies essentially showed that compared to giving the patient best medical management, in those patients who had large vessel occlusion, about 40% of them had a better outcome compared to the patients who did not. So these trials have essentially caused a change. So now stroke thrombectomy is offered to, if you're within 12 hours after onset of symptoms, then you can still be eligible for thrombectomy. So, as you know, I mean, our nature is that once we get good results, then we want to try even harder to see how many more of these stroke patients we can help. And the DAWN trial, they looked at thrombectomy at 6 to 24 hours after stroke symptoms. However, these patients now go through a more rigorous investigation, meaning that they would need advanced studies like your CT perfusion, your MRI, to look at the deficit compared to the infarcted brain, because we cannot save the already infarcted brain, but more the penumbra around the brain. So the area that is being perfused but not great. So if we get back perfusion in time, it will actually result in improved outcome. And I don't have a video, but it is quite dramatic. These patients who come into the emergency room, significant slurred speech, dense hemiparesis, with a large vessel infarct, you take them to thrombectomy, take out the clot, and before coming off the table, they're speaking better. They can do, there's no pronator drift, there's improvement in their neurology. So the DAWN trial essentially has now pushed us, because at this study showed that at 90 days, there was 49% in the thrombectomy group compared to 13% in the control group. So there was improvement, or patients who had functional independence at 90 days compared to those who just had the best medical management. I know, I mean, these are all great results, but of course, in our setting, we have to be careful in terms of where we start. And in our own practice, we have started with the standard cases within the 4 to 6 hour guidelines. We have done a few of the delayed ones, but it's a young stroke program, and we are still trying to establish a stroke program from essentially door to door. Our ambulance care is a major, access to ambulance is a major challenge, but for those who make it in, they are being considered. So the class 2 recommendation currently is for patients within the 16 to 24 hours time window, good functional baseline, with disabling stroke due to large vessel occlusion and tissue at risk, then they can undergo, you can offer them thrombectomy. Beyond the 24 hours, I mean, we're pushing it here again. There are some studies showing that there is benefit to some patients, and the Mr. Clean Late that also suggests, after that time. So overall, there's as you go further out from the grade 1 recommendation, you have to get more, more multidisciplinary input on deciding to proceed with a thrombectomy, and looking at the special studies like your MRI, etc. Posterior circulation strokes, I know all the evidence are stronger for the anterior circulation, meaning your MCA, your ACAs. But in the posterior circulation, patients who have basilar artery thrombosis, etc., thrombectomy within the same period of time, there's good outcome in terms of functionality. All right. So when I talk about the advanced imaging, so here is the MRI brain. So in the patients who in your standard 4 to 6 hour from onset, we wouldn't do an MRI. In patients who are going beyond that limit, you have to get an MRI to see if there's an established stroke. And some of the concerns with the MRI is a lengthy exam. It's very good for your posterior circulation, and it's not always available compared to a CT. So your CT perfusion, essentially what it does, it shows whether the area that you're identifying on CT is as ischemic area, whether it's infarcted or whether it's ischemic based on the blood flow, the cerebral blood flow that is going to that area. And based on that, if there's a significant mismatch, meaning that there is a suggestion that there's a smaller infarct, but there's a significant amount of penumbral that you can save, then it would be worthwhile, even if it's late, to still embark on thrombectomy. There are several different types of CT angiograms that we employ, the single or multi-phase. And essentially what these multi-phase vessels, CTAs do, they give us estimation of a true thrombotic length, or the period of vessels that have been occluded, and also if they are collaterals. And in patients who've had multiple small strokes over time, many times they have collaterals, and hence when you see a large vessel occlusion, sometimes the neurology may not match because they have good collaterals, versus someone who has probably never had a stroke or before, but presents with a large vessel occlusion, maybe from a AFib with an embolus that has gone to the middle cerebral artery, and they have no collaterals. And the multi-phase CTs are essentially a good predictor of outcome, because if you have good collaterals, then your infarct or infarcted brain would be less than if you have no significant collateral. But this was just describing the different phases that you look at during the CT, and that will guide your recommendation on thrombectomy, especially in delayed fashion. All right. So what about the changing dynamics? So COVID-19, I mean, as it has been echoed, has brought on a lot of changes and open our minds to take on things differently, to approach things differently. And what essentially has happened to in some stroke units, like in the UK, they've used AIs for patient selection. So when a stroke call comes in from the ambulance, there's a stroke patient coming, these are the symptoms, this is the time they were last seen. Well, the emergency room prepares, the neurologist waiting at emergency department, there's a thrombolysis nurse, etc. Once a patient gets into the door, they go straight to the CT scanner. So it's a system, the patient doesn't even come off of the stretcher to be placed on a different stretcher. They go, no, everything is timed. They come in on the ambulance stretcher, that's the stretcher they go to CT with. The CT is done. Now, once the CT is done, there's a software called Brainiomix, and what it does, it calculates the aspect score, and then that now is transferred to the neurologist, the stroke intervention phone. So at any hour of the night, by the time you've gotten that text that that stroke patient is there, you've gotten an aspect score, so you don't need to go sit at the computer and spend 2-3 minutes trying to calculate the aspect score. It comes to your phone, and then with all the other information, you decide, okay, do I bring in my thrombectomy team? Or is this one just for thrombolysis or not? So the AI has been introduced, and of course, as you know, Dr. Cox went through all the pros and cons. Definitely, I think in radiology, interventional radiology, neuroradiology, it has been in other areas of neurointerventional radiology been a part of, introduced, and I think it's something that will stay. So essentially, this is how the app works. The scan goes to it. It picks out the Alberta score. It shows you where the occlusion might be, and then you make a decision from there. So, you know, this is going to evolve. This is 2020, and I'm sure we've gone further from there. Because if you've been in a stroke institution or environment, there's often, you know, sometimes out of back and forth between stroke intervention, the stroke neurologist about, you know, what do we think the score might be, etc. So I think the AI may help to guide some of that, or maybe be a tiebreaker, who knows, but definitely in terms of helping just sort of getting to the point. And I think it's not difficult to learn, because we've also involved AI in terms of picking up some of the brain tumors, whether they think it's high grade or not. And the results have shown that there's a high sensitivity and specificity in AI is picking up whether it is a high grade or a low grade lesion. So I think the learning for the aspect score, for example, should not be too technical for AI learning. And, you know, in essence, that is where we are now with our stroke intervention. Our hope is that in time we can have the ideal flow and pattern of stroke thrombectomies, like in the first world. And I think it first starts with, you know, the primary, having our ambulance care, getting stroke certified, which we're on our way to get stroke certified. The numbers of patients who are having significant or permanent deficits, loss of job, family member having to either stay home to take care of them, is quite high in Jamaica. I think Dr. Morgan Channel, who is part of the Stroke Alliance, presented, I think, just at one institution, there were more than 1,000 strokes in the last year, which is quite high. And we know that rehab, access to rehab, etc., can be challenging in our setting. It's not like, you know, first world where you see automatically by PT, OT, you go into rehab, etc. So if you have a stroke intervention care that will improve your outcomes, and patients can actually return to their baseline function. This is just a picture of our interventional suite at University Hospital and our team. I think we're doing a calling an aneurysm here. But thanks again. This is our current format that we're going with, the AHA guidelines that was updated in 2019 for now, but we are still sometimes doing some stroke interventions for patients who fall in that extended period or outside of the time or guidelines. Thank you for your time and listening.
Thank you so much. A very informative presentation, Dr. Tyndale. We are making strides in Jamaica, and I'm happy to see that. And I'm sure that persons who were not aware of this kind of practice at the University Hospital, especially for the peripheral hospitals, are now aware that we have a stroke intervention unit at the University Hospital of the West Indies. I was trying to see if we had any questions in our dialogue box. I now invite questions from attendees.
So there's one question. Excellent presentation. Excellent information. We have a far way to go in the successful management of stroke, especially in the peripheral hospital. Patient education, availability of service, accessibility to healthcare institutions, CTRs are major challenges. The question is, what is the cost for thrombectomy?
Yes, thank you. So one of the other challenges with stroke in Jamaica is the cost, because even for thrombolysis is about $500,000 for the TPA. For thrombectomy, those disposables are not stored or on shelf. So that has to be purchased, which can take you up to probably about $1 million Jamaican dollars. And that's just a rough estimate depending on the equipment that you use for the particular case, you know, depending on where the clot is, how stubborn it is, how long it's been there, etc.
Okay, thank you. There's another question, just asking which one is better, a CT or an MRI? Which one is preferred?
So for stroke, the CT is the first, that is the first step. That's the first imaging that should be done. The MRI is more, especially in a delayed fashion, is more prognostic, or in the case where you're considering thrombectomy in a patient that falls outside of the standard guideline for thrombectomy.
Okay, thank you so much. Are there any other questions? All right, thank you so much, Dr. Tyndale. We have come to the end of a very informative, there's another question. So the question is, how can anesthetists contribute to this initiative in helping the process to have patients identified and done efficiently? Dr. Tyndale?
Great, thank you. So one of the in our stroke initiative or stroke certification, in our planning, the anesthetists are actually a part, or IC is a part of the team in getting stroke certified, because most times we do thrombectomies with the patients awake. But if they're very uncooperative, you may require, you know, some assistance in terms of sedation, etc. But primarily these cases, we attempt or aim to do them awake.
Okay, thank you. I hope that answered the question for Ms. Gooden. Thank you so much, Dr. Tyndale. We have come to the end of the first half of the webinar for today. A very powerful and informative morning, and a lot of food for thought and information for sharing. We are now going to be proceeding into the second half of today's webinar, and I will be succeeded by Miss Lorna Calder, nurse anesthetist, nurse anesthesia educator, College of Health Sciences, UTEC, and JANA. Ms. Calder, are you on? Lorna Calder?
So Nurse Calder is on. Nurse, can
Yes,
you please?
I am on.
Can you please allow the request where it's asking you to come over to the panelist side?
Sure, no problem.
Join as a panelist. I have done so.
All right. There was a question, Ms. Caldo, for Dr. Tyndale. Could you just allow her a second or two to answer that question? Is she still on?
Hi, sorry, can the question be repeated? Sorry, I missed that.
Are there any plans for subsidizing this care by the government to make it more affordable for patients? That's the question that has been asked.
Yeah, so currently there are discussions, like I said, the Stroke Alliance, this is a Ministry of Health, part of the Ministry of Health initiative. So we're still in discussions with them. Currently, however, if you need, the challenge is that the route that you have to go now for thrombectomy is through the Compassionate Fund, which is a time issue because that is delayed. But we're still in the process of having discussions as a part of the Stroke Alliance to get stroke certified, etc. So that is part of the consideration, that the costs will have to, I think, for most patients be subsidized, because that's a serious challenge that we've had with the interventional cases. Even before the thrombectomy, thrombolysis, the TPA is a challenge, and they're, I think, going to start there first, and then I think get to the interventional part of it to see how they can subsidize so that this is available to Jamaicans.
Thank you. And the final question, where else other than UHWI that this service is being offered?
I am not aware of any other place in Jamaica that stroke thrombectomies are being offered. Well, I'm not aware of any of the public at any of the public institutions.
There, so here. Oh, I am now to join.
Sorry?
Sorry about that. Please continue.
Yes. In the public system, the university hospital, as far as I know, is the only institution that is offering stroke thrombectomies.
Okay. Thank you very much. Ms. Calder, over to you.
Nurse Calder, it says you're declining the request to come over. No, you've accepted. Thank you. And thank you, Nurse Dakers, for your moderation of the first session. We now hand over to Nurse Calder.
You're most welcome. Thank you.
Thank you very much. And good afternoon to everyone.
Good afternoon.
I'm being heard? Okay. So we are continuing this webinar, and at this time I am calling Mr. VC DeAndran. I'm not even sure if I'm calling that right, but he is the general manager for the Caribbean region of Indus Life Sciences PVT Limited, and he is a proud sponsor of this webinar. So over to you, Mr. VC.
Thank you very much. Good afternoon, everyone. And thanks for opportunity for Indus Life Sciences, for the JANA, and afternoon to the moderators, presenters, and also Oldgate Solution, Mr. Sam, and everybody. So, Mr. Sam, can I share my screen?
Yeah, you can share your screen, and thank you so much for choosing to partner with JANA on this and being the sponsor today. Please go ahead with your presentation.
Yes, sir.
All right, everything's up. You can go.
Yes, thank you very much. This is the first time I'm coming on board for JANA webinar, but thank you very much. And for those who are not aware of Indus, we are based in 3 Carifta Avenue, Kingston 11. That's where we are based at. And what does Indus stands for? It basically means I and us. That is Indus. I and us together serve the community. That is Indus. And we have also OTC brands, over-the-counter products, plus we have some prescription medications also. But today I thought, let me just present 2 of our over-the-counter brands, which you could be found it useful for your patients, customers, as well as sometimes maybe personally also it may be useful for you. So one of the product that we introduced not long ago, around a year ago, that was 2022, which is for especially for those who suffer from conditions like heartburn or hyperacidity, gastritis problem, gas problem, acid reflux, or even for the matter pain, gastritis pain. So when you come across persons like this, a simple solution could be an antacid. Of course, H2 receptor blockers, proton pump inhibitors are available, but the antacid offers fast symptomatic relief. So that's the benefit of antacid. So the challenge is that if you talk about antacids, we all know there are many brands of antacids are available across Caribbean, even in Jamaica too. So the challenge is that how to select a right antacid. So probably my presentation will guide you to select the right antacid. One of the first step is that to identify the benefits. And for that matter, the antacids has been classified as generations. The first generation antacid, second generation antacid, like that. The first generation or the older generation antacids are the basic antacids, which are basically meant to neutralize acidity because of the ingredients that offers. It offers magnesium hydroxide, aluminum hydroxide, magnesium trisilicate. These active ingredients, the role is to neutralize excess acid that is secreted. But the challenge is that in case of ulcer, it is not only the acidity that is a problem. Quite number of people will suffer from gas problem, and acid reflux is quite common in ulcer patients, and pain is also there, and acid reflux is also very high, which leads to heartburn too. So that's where the second generation antacids came in the market. Interestingly, whatever brands that today you see in the pharmacies across Caribbean, of course in Jamaica too, they all falls under second generation antacid. They are basically helps to neutralize excess acid that is secreted, and also it helps to relieve the gas, which is flatulence, because they offer the additional medications like dimethicone and simethicone, along with the aluminum hydroxide, magnesium hydroxide, and magnesium trisilicate. But the pitfall, the gap in this antacid is that they are not still complete because they have nothing to attend GERD, gastroesophagus reflux disease, which is nothing but acid reflux, the movement of stomach acid content moving from stomach into the esophagus, which sometimes become very serious. After dinner, if you lie down and it throws up and the intensity is high, sometimes we get confused, think it is a heart attack too. So for this existing antacid has no answer. That's where first time in Caribbean, Indus has introduced this new antacid called as new gel. Even though you see in the screen as first time in Jamaica, I request you to read it as first time in Caribbean, because nowhere in Caribbean a preparation like this is available. We are the first company. Indus has introduced this. The difference with this the new antacid, which is actually classified as a third generation antacid, is it offers a unique ingredient, which is alginic acid, that makes this antacid different from rest of the antacids that we see currently in the pharmacies. What is alginic acid? Alginic acid is basically an algae, is a natural algae, and how it helps to stop GERD or acid reflux, or how it stops heartburn is very interesting. When anyone takes this antacid, the alginic acid in this antacid new gel, it interacts with stomach acid content and forms a foam. As you could see in the screen, the white that is part is the foam formed by the alginic acid, and it is referred as alginate raft. This alginate raft floats over the stomach acid content and acts like a cap or like a barrier, and does not allow the acid content of the stomach moving from stomach into the esophagus. Thereby, the acid reflux, which is called as GERD, and heartburn is prevented by this antacid. And obviously, new gel also offers other medications, and this clip will show you how effective it is. You could see the new gel, the antacid goes into the stomach. The alginic acid in this antacid interacts with the antacid, with the acid of the stomach, and forms the foam, and this foam floats, and whenever the acid tries to move up into the esophagus, it blocks it. N number of times it attempts, every time it is blocked. This foam is formed in just 4 minutes of taking the antacid, and it stays literally more than 5 hours. After that, 5 to 6 hours, it gets excreted or evacuated along with the stomach content, and no residue is left. So now we understand how this alginic acid prevents acid reflux or heartburn. Just let me run this clip again. You could see here very clearly the alginic new gel goes into the stomach, interacts with the stomach acid. The alginic acid in this forms the foam called as alginate raft. It floats over the stomach acid. When the acid content of the stomach tries to move up, it blocks. Again it tries, it blocks. Again it tries, it blocks. And this is formed in 4 minutes and stays more than 5 hours, and then it gets completely evacuated. When patient takes the next dose of the antacid, again the same alginate raft is formed. Same way it blocks, and then it prevents acid reflux. So thereby, this is the first antacid in Caribbean which stops GERD, and the regular and acid neutralizing medications like magnesium hydroxide, aluminum hydroxide, magnesium trisilicate, they know we neutralize acidity, excess acid that is secreted, and the dimethicone is anti-flatulence. It relieves gas. So that's the benefit of new gel. And new gel is registered across Caribbean as over-the-counter, including Jamaica. No need for prescription. You can go to any pharmacy wherever you are, and you can look for it. You can just pick it up from the shelf. And it is sugar-free, so we know it is safe in diabetes. And please look at the screen. It is safe in pregnancy also. That means any trimester of pregnancy, first trimester, second trimester, third trimester of pregnancy, it can be recommended. As it is safe in pregnancy, obviously it is safe in children. I mean, children less than 10 years of age can be given new gel. The dose is basically 10 ml, 2 to 3 times a day is recommended for adults. Children, it is 5 ml, 2 to 3 times, depending on the age. So it is recommended. So new gel has a mint flavor. So obviously it helps for digestion. And actually we are not stopping here. We have extension of new gel. By the way, the new gel, the brand name is coined just to communicate that this is the first, third generation or the new generation antacid. That's why new gel. New generation antacid gel, new gel. That's how it has been coined. And we are not stopping here. We are also giving an extension of new gel, which is also referred as mother of all antacid. That is a nickname. What is this mother of all antacid? That is new gel O. As you could see in the screen, the O is oxytocin, which is basically a mucoso anesthetic drug. Just like lidocaine, we all know, this oxytocin is also anesthetic medication, which can be taken orally. And when persons take this new gel O, the oxytocin coat gives a coating to the stomach wall, the mucous membrane of the stomach wall, and relieves pain associated with gastritis pain, especially ulcer pain, duodenal ulcer pain, and so stomach pain. And you could see here it has alginic acid, and we just saw the alginic acid benefit in the clip. It prevents GERD, it stops the heartburn, and it has regular magnesium hydroxide, aluminum hydroxide, magnesium trisilicate. We know the benefit of that. It neutralizes acidity, and the simethicone in this is anti-flatulence. It relieves gas. So this is the first antacid, ideal for heartburn, ideal for GERD, neutralizes acidity, relieves gas. Of course, it relieves pain also. The only caution in this or contraindication, new gel O is not recommended for pregnant women, and any persons less than 10 years of age is not recommended. If the pregnant mother has episodes of throwing up, better recommend new gel. Non-pregnant women and those who are about 10 years in age, you can consider new gel O because of the benefit it offers. So this is the indication for new gel O, and this can be combined with the regular anti-ulcerant medications like proton pump inhibitors, especially your omeprazole, pantoprazole, lansoprazole, and all. It can be combined with H2 receptor blockers like ranitidine, cimetidine too. The basic benefit of this is that fast symptomatic relief. That is new gel and new gel O. By the way, new gel O is also over the counter. It's also sugar free. So, and we have new gel and new gel O in 3 different pack sizes. We have regular 200 ml pack that is available. It priced in Jamaica. The plain new gel is around $800 to $850, and the pharmacy sold to the patients. And we have 100 ml pack size also, which is just roughly around $500 to the patient from the pharmacy. And also we introduced first time in sachet, that is single dose 10 ml sachet. This is especially for people who are going for restaurants or working or just traveling for a day. You don't have to carry a whole bottle. You can just pick up 1 or 2 sachets as they need it. And it costs around $45, something like this in the pharmacies, which is 10 ml sachet. Same way, the new gel O also available as 200 ml pack size, which is around $900. And the new gel O 100 ml is available roughly around $550 to $600, and the sachet is around $47 per 10 ml. So they are both of them sugar free. Both of them are over the counter. All the pack sizes are over the counter. So this is new gel and new gel O. And the last product which I just wanted to just refresh is or present is about our amino pep. I'm pretty sure most of you must be aware of this supplement. This is the first supplement in Caribbean which offers not only vitamins, but it offers protein. It has 10 essential amino acids, and that helps to form protein, and it has minerals like zinc is also there, and this is actual composition of amino pep. Trust me, no other supplement in Caribbean can come close in terms of composition, as because the amino acids are ideal for immediate protein synthesis, plus it has a whole range of vitamins, plus it has zinc for immunity, which is 50 milligram of zinc is also there. And indication is quite wide. 18 months and above for children is recommended. Less than 18 months, mother's milk is the best. And grown up, it is recommended. And those who are in ICU, it is recommended fast to speed up the recovery, convalescence, and also for elderly people, it gives sense of well-being and improves the exercise performance also. So that's our amino pep. It comes as 200 ml pack, and the dose, as you could see in the screen, 10 ml 2 to 3 times. Kids 5 ml is recommended. And just to conclude, before 5 good habits we all should try to practice. One is a bit of exercise, at least 30 minutes of walking a day, and obviously we should eat nutritious food, and we should all have adequate to drink water, and 7 hours at least good sleep is recommended, and not last the least, it is 10 ml amino pep a day can give you a healthy life. So for any of the samples that I presented today, so if you request, if you need it, please WhatsApp to this number. We'll organize to deliver the samples to you. Thank you very much. Thanks to JANA once again. Thanks, Mr. Sam.
Thank you so much, Indus, for your presentation, sharing with us, and of course, sponsoring today's webinar. Nurse Calder, back to you. Are you there?
I am.
Wonderful.
Thank you very much, Mr. VC. And let me especially also thank you for your joining with us at JANA. Just want to say to us, the 7 hours of sleep that Mr. VC recommended. Wow. Us nurse anesthetists, we know how difficult that is. We will continue though, and at this time to tell us about the critical care in the digital age is Mrs. Marsha Downer Campbell, and she is the clinical nurse manager of the intensive care unit at the University Hospital of the West Indies. Sister Downer Campbell, your turn.
Good afternoon, everyone, Madam Moderator, fellow panelists, participants. Thank you to JANA for this invitation to this very timely and really important session. I have no disclosures, but I want to also inform you that I'm not certainly an expert in this area of digital technology, but I am going to do my best. And in my preparation for this presentation, I, came upon a lot of challenges. But one of the things I found, and I thank the presenters that have gone before, they really prepared the way. And I did get some assistance from AI in completing this presentation. I would have gone down a rabbit hole, I'm sure, had it not been for that assistance. The information out there is vast. And so, you have to navigate carefully how what you put in the search images, the search messages to get the information that you want. So I just want to also say that this presentation, brief as it will be, I hope it will be beneficial to all the persons on, and that we are able to see what the possibilities are. All right, so it's about the possibilities. I know we have a lot of concerns about how technology is going to impact us and healthcare. So what we're looking at today is the possibilities. All right. So in the dynamic landscape of modern healthcare, the integration of digital technologies has revolutionized every facet of medical practice, and nowhere is this transformation more evident than in the critical care realm. The convergence and advances in monitoring systems, real-time data analytics in medicine, and yes, AI has ushered in a new era of critical care in the digital age. All right, so in this exploration, we
Everything okay?
will delve into the Yes, you're not hearing me?
So your audio went out a while ago. I think it might have been your internet. I'm seeing some red strokes there for your Wi-Fi, but we're back now. I'm seeing critical care as the slide that you're on.
Oh, what was the last thing you heard?
It's a very good question.
All
Kind
right.
of close, but you're on the critical care page. So if you could just start over the slide, that would be great.
So no, what I just completed was the introduction.
Okay.
So last part of it is that, you know, we are going to be looking at delving into the profound implications, challenges, and innovations that characterize the synergy between critical care and the digital age. First, we want to look at what is critical care. And critical care, also called intensive care, is medical care for persons with life-threatening injuries. This care usually takes place in an intensive care unit by a team of specially trained healthcare providers who give 24-hour care. And this includes using machines to constantly monitor patients' vitals. It involves giving specialized treatment. So what happens in a critical care unit? Well, persons who are familiar and even unfamiliar know that we have a lot of equipment and devices, and this helps to monitor and care for the patients. So we have machines that deliver medications and feeds. We have machines that deliver oxygen, check vitals, and display this on a monitor. We have ventilators or breathing machines, which move air in and out of the patient's lung. We have dialysis machines for persons with kidney failure, and we use devices which include catheters, which drain fluid, or if you need to give patients fluids. We have feeding tubes, and we have endotracheal tubes entry. This is just a small amount of the many machines and devices that are utilized in the care of a critically ill patient. So what is the importance of critical care in the healthcare system? So in the critical care setting, we manage critically ill patients. Who are at risk or have developed treatments, patient safety, end-of-life care, ethics, and the support of families is paramount in the critical care setting. We give, it is a life-saving and dynamic branch with the responsibility of managing the sickest patients in hospital. A well-equipped ICU can provide facilities such as respiratory and cardiovascular support, renal replacement therapy, radiological bedside investigations, echocardiography, ECMO, and intra-aortic balloon pump support. And this is just naming a few of the things and the support provided by critical care. So leading from that now, we're gonna talk about digital transformation and the age of digital transformation. And in the research, I think we started to see things changing really in maybe about 1995. based on the research and from my memory. But what is true is that in the last 20 years, there's an explosion in the use of technology in all areas of life. I remember a couple of years ago, we had a minister that was when the cell phone became a thing. People had 2 cell phones, and, we just really, the one day we were at Bangor, and the next day, everybody had a smartphone. That's how it seems. So there's really been an explosion. So the technology has moved in what we refer to as waves. And the first 3 waves were we saw the advent of the personal computer, the widespread use of the internet and mobile devices. And now where we are here in what we call the 4th wave or the 4th revolution. And a lot of persons are afraid, other persons are not sure, how we got here. But waves. So in this 4th wave, we're going to be seeing, or we have already started to see, augmented mixed reality, and that is bearing down upon us. And I know a lot of persons are going to be asking what are the mixed reality. I don't want to go too much into those, because that's not really where we are going, but I'm going to encourage you to look how what is happening now in the 4th wave. We alluded, and the previous presenters, so a lot of it, the use of AI, the use of this type of technology to support what we do in the healthcare setting. So how has this technology transformed healthcare? Digital transformation is essential for meeting the requirements of citizens to deliver health services efficiently and effectively. In healthcare, digital technologies are used to research medical knowledge, facilitate clinical support, monitor the quality of care, map and track infection, simplified processes, providing care on patients' terms, helping patients stay well, offering continuous patient engagement, increasing efficiencies, and raising staff productivity. And what has been the impact? And the previous presenters spoke to quite a few of these. I think we had one presenter dedicated to the use of electronic health records. Somebody else spoke about telemedicine, and all of this, culminates in how we give care. Communication among medical professionals has been improved and can be more see further improvement through the use of technology and data analytics. Data analytics is a big thing because this allows a large amount of data which we couldn't normally do to be analyzed. It puts all the data that is input together and analyze it so that we can, get a real picture of what's happening with the patient. So what has been the impact on critical care? And I just want to show this brief video of what is happening in one hospital. And a lot of the changes that we're seeing came out of COVID, so they were born out of necessity.
Michael Dieter has been awaiting a lung transplant at the University of Florida Health Center since December.
I have what you call high flow air. And because of that, I can't sustain myself at home.
A dedicated team of doctors and nurses attend to him day and night. But that's not all. Sensors and cameras track Dieter's every move in this smart intensive care unit, from vital signs to facial expressions and everything in between.
Every place in this room will sense something about you. Is this enough light? Is this enough noise? Are you okay? Are you moving it now? Are you in your bed? Are you out of the bed? I think that's the future of how we will design hospital.
More than 350 gigabytes of information per patient goes into a central computer, where artificial intelligence then processes the data. We could look at the patient and go, they're moving a lot. There's something going on there, or their face has a certain grimace to it that they normally don't have. Is it possible that it could tell you before I even know that I'm having problems?
Yes, 100%. We will be able to decipher complex features, complex emotions like agitation or hunger.
Funded by the National Institutes of Health, the high-tech experiment enters its third year. Researchers are still teaching the technology what certain actions like sitting and standing might indicate. The hope that AI will soon be able to provide real-time healthcare recommendations. Nurses, doctors, we spend a considerable amount of time paperwork, translating the data we get.
You will actually have a representation of the data in a way that you as a human can just understand and action.
But will this new technology replace the need for humans in the hospital altogether?
They are very simplistic models compared to what our brains are doing. And I don't think that we should be worried about humans being replaced anytime soon.
That this technology does take big burden off the physicians and nurses and provide them time to actually engage what we are here for, taking care of the patients.
A new holistic approach to healthcare where humans and computers work hand in hand. Dr. John Torres, NBC News, Gainesville, Florida.
All right, so I hope that that video is just a little bit of what is possible and what is happening very close to us. This is a hospital in Florida. I know that we are not anywhere near there. We're way behind, but we will make the most of what we're able to do. The cost for these things are significant, and we will look at what some of the things that we can use and are in fact using some of these in our critical care settings. So we will look at electronic health records, remote patient monitoring, medication management, and clinical decision support. Electronic health records, this assists us in that it is if it's a good system, so that is very important. If it's a good system, and quite a few of the presenters before alluded to the choice of system. It's not something you choose randomly, it's something that's discussed, and you choose what is best based on your setting. So this should allow automated entries. So as in with the paper base, you go every day and you head up a sheet of paper, but with the electronic health records, automatically this information comes up each day or at the point of each entry. Yes, faster retrieval of patient information, that should be possible. You shouldn't be searching through and trying to decipher who sent this, who did what. It should be a simple system. It should improve data accuracy. So things like misspelling and, if in the paper-based, and I'm not knocking anyone here, a doctor comes in and writes a complete order, and it takes 3-4 persons to interpret what was written and what is, so with the electronic health records, you remove that aspect, not just accuracy, but the legibility of what is written. Unstructured text can be interpreted and made clearer, so it can be understood and instructions followed. And as most of us would know with the manual entries, if you've done any auditing and look at what is documented, there are a lot of errors and it is time consuming. Yes, data entry also with the electronic health records can be time consuming if it's not the best system suited for the area, then it also can be time consuming. Remote patient monitoring, the provision of charts, graphs, patterns through continuous monitoring will enable nurses to better interpret and understand what is happening with a patient. The data provided can be easily read and understood and lead to timely assessment of the patient. You can easily compare what was done today, what was done last week, what was done a month ago. So it makes for easier assessment and analyzing of the data that was inputted. Medication management, and this is a big thing for nurses. Technology can provide nurses with an immediate comparison of the client's current medication and the medications previously taken. Look at a client's medical history and identify discrepancies. So all these things the nurse wouldn't, or even the doctor wouldn't have to do, because the system is such that once this information is inputted, then just that one statement will, or one medication would cause all of these things. And one of our previous presenters spoke about at what point. So it could be at the point at the pharmacy, at the point when the doctor makes the order, at the point when the nurse prepares the medication. Then you would see, well, how this drug interact with another drug the patient is on, or the conflicting orders. This drug doesn't work well with this one, will pick up some inconsistencies. And through barcode scanning, medication administration, safety and efficiency can also be improved. Technology can also provide optimized medication inventory management, include usage patterns, allowing nurses to ensure adequate stock levels, reduce waste, and avoid medication shortages. The technology also allows nurses to have immediate access to drug information, doses and drug interactions, drug administration guidelines, including drug calculation. All this will lead to improved nursing accuracy and timely intervention at the point of delivery. Moving this around. Clinical decision, it can promote standardized care in a previous what is standardized or what is the best decision for the patient. The decision is evidence-based and recommendations are made to ensure patient outcome. Through the use of artificial
All right, apologies everyone. I think we might have had some internet issues that had us lose our speaker. Please give us a little bit of time to see if we can get her back online. What an awesome presentation it was as well. Aye. So again, we want to thank Indus Life Sciences for sponsoring today's webinar. Nurse Calder.
Okay. Yes.
So I think we can give Nurse some time to return.
Yes.
2 minutes or so.
Okay. All right. So at this point, while we're waiting for Sister Donna to rejoin, just to a point to note that in this era, as it is now, we're having some connectivity issues, and I I don't know how our audience, our colleagues, how their connectivity is in their place of work, but I'm just wondering what sort of challenges we will have when the entire system is fully digitalized. Then how will we deal with this in terms of a support, a backup system? You know, I don't know if anybody in management has anything that they can share, or do they know what the plans are for the system generally?
I'm not sure if I have anybody on the panel who would like to take that. But I'll say though, when it comes to systems, you have internet systems or Internet of Things, such as what we're doing now, which depends on ISPs. But remember, it is also possible to have private systems. So if the hospital or medical system or the government as a whole decides to do a closed system where everything is on its own network, it won't require internet. It will only require electricity. So that's also an option. Nurse Kushni, you have your hand up.
Yes, thanks, Sam. Thanks, moderator. Just to share my experience, my current experience, I think when we're heading into the digital era, one of the things, planning is critical, because sometimes what we have is that our foundation, what we have existing in terms of our electricity supply, if we don't have a backup system, if our internet, if our bandwidth is too small and we're spreading this all over different areas, we get challenges. Because at some points you have, because for instance, on one of the wards, when you move beyond a certain point in the area, the internet access was, the Wi-Fi access was so poor, you know, the connection was poor. So we really, it has to it takes a lot of planning, forethought before going full speed into, you know, going fully digital. And this is some of the things I think sometimes the persons who are putting the plans in place have to get a better feel of what happens on the ground before actually trying to put this system going full speed ahead with systems like these, because there can be, and there have been, significant challenges that we are seeing going forward in trying to get into the digital era fully. So proper planning and just getting a feel of what is happening at the point where it's going to be utilized is very critical.
Thank you. One of our speakers this morning had asked if we could remember a time when we never had the cell phone. And as a senior citizen in this business, I remember that in the beginning, there were some unwritten policies that we were not even allowed to charge our cell phones on the job. And it was a little bit, you know, a little bit of a disgust, because we were like on 24 hours duty, and sometimes your phone is not charged and you couldn't get some things done because the telephone system in the hospitals, the landline facility rather, is really not there. And so that is where we're coming from. We are seeing now where, as anesthetists especially, we are being asked to become photographers, because there are times when the assistance that is needed is for a photograph to be done so that the senior who is not on the site at that time can offer the assistance that is needed en route. And each time, you know, we have to do something like this, I'm saying, my God, will we be able to afford the tickets, because you know that if you are using your device, it's a ticketable offense. And, you know, we're saying how the sacrifices that you are going to be making, because at that time, the focus is not so much on the ticket that you're going to get, but rather to help to find the solution for that situation that exists that caused you to be on the phone. That is that's my little observation at this time.
Thank you so much. Wonderful observation. All right, so I do think that we might have lost Mrs. Donna Campbell, unfortunately. If she does rejoin us, I think we can try to fit her in where we're able to. In the interest of time, I would recommend we move on to our next presenter. And so for that, I'll hand over again to you, Nurse Calder.
All right. Thank you very much, Mr. Sam. So at this time, we would want to hear who is using our facial recognition and humanity. And to give us this information, to do this presentation, we have Miss Cleanna Smith, who's an attorney at law of the law firm Attorneys Smith, Robinson, Miller and Company. Let us welcome Miss Smith to make her presentation.
Muted.
Is she on?
Good afternoon. Are you hearing me?
Yes, yes. Thank you.
You're hearing me? Sorry.
Yes.
We can hear you now.
Good afternoon, everyone. And thank you for inviting me for today's webinar. It's my pleasure to share the knowledge I know and I'm acquiring in the area of artificial intelligence, which covers a wide cross-section of our lives, be it social, medical, psychological, infrastructural kind of setting, and also legal. I do trust that the presentation will assist us as we properly plan to use the technologies available and to make the best of it. Now, my paper is entitled, Who is Using My Face? And we could say, who is using your face? Facial recognition technology and humanity. I'm just about to share my screen so that we could have a look at the presentation. Just a second. You can confirm with me that you're seeing this screen?
Confirmed.
Confirmed. Okay, so it's facial recognition technology and humanity. And whilst I was preparing this presentation, which was done for another conference, I had to stop for a second and just to reflect on the ethical practices that we engage in using artificial intelligence, even though it's so much of a great, what I'd say, a great impact in our lives today, just to reflect on the ethical concerns in relation to the technology. And I have here a photograph which shows the evolution of man and computer. And we see a very big computer to start with, and the person is so small. And then as the technology progresses, we see where the technology becomes very smaller and the human being is becoming so much bigger because we're so stationary these days. But when I started preparing this paper, my desire was to have a complete and sensible academic paper with a primary focus on the academic aspects of the paper. However, I was confronted with the task of reformulating the paper. And at that point, I realized that my perspective must change. And so I did not take on the duty to prepare a complete academic paper, but one that would share the bit I knew about the technology as it is now. If I should share that only a few months ago, I lost a very good friend of mine who is quite interestingly, the world's first robotic psychiatrist. And I met her about 7 years ago. And she said to me, Sienna, the world is changing and it's changing very fast. And she would have explained from that time her contribution to robotic technology. I know she was focusing on healthcare and assistive robots, social assistive robots in artificial intelligence and the new world to come. But when she said that she was the world's first robotic psychiatrist, I found it very, very funny. And frankly, I laughed because I was wondering, why would we need a robot, that would need a psychiatrist? But now we see, as we are progressing with the technology, if we're going to have robots who are performing duties as doctors, as teachers, as nurses, as caregivers, then we know not what the end will be as it relates to how sentient they'll become and how they will interact with human beings. And the fostering of the interaction of man and robot or man and machine systems will be an interesting time. And that's where Ms. Joanne Pransky, which is her name, would have been very critical and where her work will definitely play a role in the future. So God bless her soul. But if we're entering an age where we'll be identified by our face, then we should at least understand the technology guiding the future. Individuals passing through airports for business or for leisure will likely pass through airports containing various checkpoints which will capture facial biometric information. They should know what the technology is and what it represents. And we're speaking on the issue today of AI in medicine, and a lot of the information that is stored, captured, stored, used for our healthcare advantage is dependent heavily on your facial biometrics, and then your organs, are both interrelated, because you must be able to identify who this person is to then say what perhaps is wrong with the individual if we're going to be looking at healthcare advancement. So there are two articles which will form the bedrock of this presentation. And the first one is, who is using my face? And this article left me with a big question as to where exactly is my face. And the second article is the ethical questions that haunt facial recognition research. And this article made me wonder about the future ethics of facial recognition technology. And a lot of us may or may not know that there are companies now that will gather your data based on your shopping list, and they are able to provide that information perhaps through certain partnership agreements with, for example, insurance companies. And so soon that information, that data, which is your grocery shopping list, may determine whether you're likely to be affected by a certain illness. So if you have a very long list of sugar content on your grocery list, then perhaps you may be open to cancer, you may be open to diabetes, you may be open to, I may not know the ambit of the legal, the legal defects or deficiencies, but in the world of AI, systems will be used to perhaps forecast what your illnesses may be, depending on the things that you consume and the places that you go. So in the age of the AI, there is still a lot which is unknown. Now, with all the above said, I trust this paper will be a guide to those who are truly interested in the future of humanity and those who are truly interested in the future of technology. This is just an overview of what the presentation will look at: the definition and the concept of facial recognition technology, the history of facial recognition technology, news on facial recognition technology, development of facial recognition technology. Then we will assess the methods of facial recognition collection without consent, and even in medicine that may be a concern as well. Examine the ethics of facial recognition technology and exploring who exactly is using your face, and then just discuss generally governance of the technology of AI as it touches all areas of life. So what is facial recognition technology? Facial recognition technology is computer software which identifies a person by using their face. This can be whilst you are alone or whilst you're in a crowd. Facial recognition requires the dimensions of your face to know who you are, where you're from, and any other pertinent information. And as we speak about medicine, it's amazing to know that you may have certain illnesses in one jurisdiction, and if you should leave to go to another jurisdiction, the database would be available to say what illnesses you do have or potential defects, any assistance, health assistance that you may need, which would make healthcare so much, softer and more compassionate. But a lot of persons are concerned with just the information itself being gathered and how the information is being used and whether you may be penalized somewhat as it relates to how you live and what data is being collected from your day-to-day moves. So facial recognition sounds great, but can I pick my own face? And this is what the comic here is saying, because whilst many are open to information sharing, and whilst many are open to having their information be used for facial recognition advancement, many are somewhat concerned about who may have this information and what can be done with the information. Initially, when we were awaiting nurse to be back online, another member of the association was asking whether there is a concern that we may have a situation, for example, no electricity. How do we handle that as we advance with AI in medicine? If we have a data facility holding and storing data information and you have critical care, if you can't access that information, what will happen? Because we're going now almost in a digital age where we are saving the trees and trying to get rid of as much paper as we can. And so the information now will be stored in data sets, and the accumulation of that requires real serious technological advancement to have that security, confidentiality, and so on. And so the wonder is, are we really safe with our information, or can our information be used against us as we function? So the history of facial recognition technology. It is said that the concept leading to facial recognition started in the 1960s, when Woodrow Wilson started his experiment on facial recognition using photographs for testing. So at this time, persons would actually give consent to say, I would like my face to be used for your database, for your experiment, and persons would gather at different photo labs where their information would be used. Photos taken from different sides, different perspectives, and then the information be used to train data for facial recognition technology. But let's look, by the year 1990, the Defense Advanced Research Project Agency of the United States of America, DARPA, was now big in technology, and major testing of the technology was now necessary. One such major testing of facial recognition software was used or tested at the 2002 Super Bowl, and many weren't aware of that. Many were unaware of the testing being done, but from the test, DARPA was able to identify previous offenders and others present at the mass gathering. So we see the ambit of the experiment going on, which we can't say is unnecessary, because in some sense may very well be necessary to facilitate the improvement and advancement of the technology itself. I think the worry is the consent and the ethics of the data being collected and what it is being used for. Developments in facial recognition technology. The development of facial recognition technology is moving with great advancement. So much that the expansive use of the technology has become a prominent global issue. I'm sure if you're leaving the island or going to a different country, you may now have to pass through various airports that require to scan your face, scan your eyes, and they'll also take your prints as well. So there's a constant monitoring of borders and border control and so on. And as the technology progresses, the European Union, EU, drafted their Artificial Intelligence Act, which proposes to restrict public artificial intelligence or facial recognition use. And in 2001, the EU members voted in favor of a resolution banning the use of facial recognition by law enforcement in public spaces. So we see facial recognition being a big mushroom of an event happening over the years, wherein your data is being collected and most of your facial data is being collected and it is being used in various arms of governance, and as we're saying, in law enforcement, in medicine, in education, and even your social life. So news on facial recognition technology, for example, the first picture says, and these are screenshots over years of researching and just keeping track of the technology. It says, I do not consent to facial recognition technology. And this was a mass move by a group of individuals who wanted to stand against facial recognition data being collected, and we'll soon see why. And then we have thousands of stores will soon use facial recognition technology and they won't need your consent. So by just entering a store with the camera systems there, your face is exposed to their systems, and they could keep your data and keep track also and store your information, and in some instances even sell that information. And this other picture says, Privacy Commissioner Mull's Biometrics Code of Practice. So there is no how do we manage on a privacy level the information being collected and the information being stored and your information being shared. So now let's look at the face and facial recognition. The previous presenter had a video sharing wherein a nurse was saying for intensive care or in healthcare, you could watch the person's facial expressions. You could do several things to monitor their improvement, or if they're declining with their health improvement, and then be able to advance medicine or to give treatment based on the circumstances or the variables being visible. The question would be, what if these are not correct? What if they are not accurate assessment, they are not accurate judgment as to what the person is experiencing? Because you rarely could look sad but not really truly sad. It may be a pretend sad, or you could look happy and it's not a real state of happiness. So we have to be very careful with how we rely on AI systems to judge or to have a judgment, especially as it relates to critical care. Now let's look at the face and facial recognition. And the individual's face is very sacred and personal. And many hate the idea of pictures floating around with their faces, especially when no consent was given. But to perfect the technology of facial recognition, billions of facial images are required to build the software. The question is, where are these faces coming from to fuel the technology? The facial recognition requires dimensions of your face to know who you are, where you are from, and any other pertinent information. As we said, for example, your health status. There are different measures in your face, and these are called facial nodes. And so the nodal points in your face, they are very, very, very critical. And we have an image here on screen that shows the different nodal points in an individual's face. And it says that there are about 80 nodal points in your face. And we're just seeing a small amount here. But an AI system is able to capture your facial image, capture the nodal points, and then with that technology, they are able to even identify whether you may have certain illnesses or whether you're prone to certain diseases. That for me can be very frightening, because we really wouldn't want to cast a judgment of illness, and on any individual where that may be gravely inaccurate. And from what we see, stress can be a number. They say, mommy is always saying stress is the #1 killer, and it's so true, because just your mind believing that you're ill could literally just make you ill, and your functioning becomes grave, I would say, in your state of balance. And if your hormones are not balanced, then it's easier for you to become unwell. Now we have systems that could literally have images captured of your facial nose, and then to test or to track whether you're ill and the kind of diseases that you may be prone to or may have. So facial nodes are very critical in AI, the AI of medicine, because it's used, we're always saying the eyes are windows to the soul, and it's very true, because your eyes are used now to capture certain fundamental information as doctors are doing their assessment of you. So measurement from eye to eye, and we're looking at the facial nodes, measurement from eye to eye, the width of your nose, the length of your forehead to your chin, even the depth of your eye sockets. And this was frightening for me when I was doing the research, because I never knew that AI was so advanced to capture your facial nodes and to have gone to the depth of your eye sockets, which perhaps may be used to differentiate between twins who may look the very same. You know, how do you tell the difference? And the depth of the eye socket may be one of the ways in identifying persons different, but this is very interesting technology. So who is using this technology? Government bodies and agencies, airports, seaports, prisons, daily surveillance of street cameras, law enforcement. In private sector, we have banking, hospitality, safety, and security. Tracking the technology, telephone, and then the internet. Then we had email, and then we have the internet changing the landscape of human life completely. For example, now we have in the UK, it is legal medically for an individual to determine the sex of their child naturally before the child is born, whether you want the child to be a male or a female. And there was great discourse on, you know, why are we limited to only the sex of the child? Why aren't we allowed to also have a say in if I want my child to be a great runner or a great artist or a great scientist, then you should be able to make that change. And the reality is there's a technology called, I think it's CRISPR, wherein there is advancement where you can actually have gene editing. So scientists and medical practitioners could actually edit your genome. They could edit that which is in your DNA and perhaps fix or amend or change as we so desire. So even though we're speaking of healthcare now on a very, very advanced level, there is this upper level of advancement that is right in our faces, it's right in the future, and it's happening now. There's also, I'll share with you another example. There is also I think it's in Germany, there's a JANA project, and I think it's CIENNA. But the JANA project focuses on genome editing and also human enhancement, which is going to be another aspect of medicine and the improvement of medicine. Perhaps you'll be able to change your organs soon. Perhaps we could maybe able to 3D print a kidney or a liver. We don't know where the technology is going, but now we do know that there is genome editing and there is human enhancement. And if it has started, the chances of it growing and advancing is very, very great. Let's look at the story of Gillian York, which is why we are having the discussion of facial recognition technology and the ethics. So even though the information is being collected for medicine, for healthcare, for social intervention, for law enforcement, as we said, the concern is how the information is being collected, because it is being collected most of the time without the consent of the individual. So Gillian discovered through a friend that her face was within a facial recognition database, being used to train facial recognition algorithms. The database had several other photos of her. Photos were taken from a variety of photos, YouTube video stills, online public videos, and even private group gatherings or settings. The photos were captured over a period of 10 years. And this was some time ago. So we see where the information was being collected of Gillian without her knowledge, without her information at all. And it was a friend who saw her face in the database who shared that with her. And then she was able to start the investigation and would have discovered that the images and videos were being collected over a 10-year period. When further research was conducted, following from the discovery, it turned out that Gillian's face had helped to build a facial recognition database used by the federal government of the United States. of America to recognize spaces of interest, including suspected criminals, terrorists, and illegal aliens. And it's very interesting. At the time, Gillian would have been a researcher who was focusing on the ethics of the technology of AI in all areas of life. And it's very interesting that her face would have been a part of that database with persons of interest, you know, when she was trying to perhaps set up a grounding, an ethical code, and to advance ethical groundings for scientists and company owners or private corporations who were collecting and selling data. I just have here the name of the facial recognition database which had her information. And it's called ARPA, the United States government body which funds innovative research aimed at giving the US intelligence community a competitive advantage. Now, facial biometrics without consent. What else are we not being told? What about AI and medicine and AI and weapons? Now, for example, in AI and medicine, we can say somewhat that the medications that we used to use perhaps 40 years ago, they are very, very, very different from the medications that we're using today. There's a lot of scientific formulas. A lot of it would have been advanced through AI in medicine. Now, if we have genome editing, if you literally can have a system that could go into your body, edit your genome, remove or replace certain illnesses or certain traits, how far can we go and what can we do? What about nanotechnology? We have nanotechnology, which is very, 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 minuscule or tiny technology that can literally go into your body, travel to different areas in your body to conduct healing processes, or maybe perhaps even in the future to harm an individual depending on the person who's using the technology. And I think that is the fear of the masses. The fear is that whilst we welcome this technology, we are concerned about the implications of it. See? So facial recognition without data. Who are these systems able to collect? How are these systems, able to collect so many facial photos? And when will they stop collecting the information? And if it's going to be given by consent, will it be informed consent and not perhaps the fine prints? For example, when you're buying something online and you see a long list of things that you should read, and everybody usually just scroll, most will just scroll right to the end, and you just click accept and move on with your purchase or move on with your transaction, whichever it is. And it may be the same way with artificial intelligence if you're using TikTok, if you're using Facebook, if you're using Instagram, you literally just accept the terms and conditions without perhaps reading through to see that your information is being collected. It may be stored, it may be shared, it may be sold, and you have no recourse because you'd have consented to that. One of the biggest collections of facial biometrics has been gathered online. And number one, MegaFace. In 2016, researchers at the University of Washington in Seattle posted a database called MegaFace. MegaFace had collected 3.3 million photos from the image sharing site called Flickr. MS Celeb, which is another one. Scientists at Microsoft Research in Washington used the world's largest data set, which is MSE Celeb at that time. And this data set consisted of 10 million images of nearly 100,000 individuals, including journalists, musicians, academics, and all were scrapped from the internet. Most of the subjects' faces have no idea that their faces were being collected in image form over several years for the building of databases for government-funded corporations, project initiatives, private corporations, and even universities for experimental purposes. Adam Harvey, who was the activist who discovered Gillian's face, he wrote a paper on the concerns with information being collected and being shared, sold, and used without person's consent. And he said that the uncomfortable truth is that many of the photos people post online have an afterline, which is being used for training your data. So whatever information is being shared, it is being used to train algorithms to identify faces, identify different races, different creeds, different based on your dressing, the likelihood of your religion that you're a part of, and so on. So many of these data sets collected without consent are being used for the building of commercial and military algorithms. The management of the world is still critical for those who govern, and so they see it important to collect this information. Now, let us look, for example, at insurance companies in medicine. Insurance companies, it's business, and we have to give credit, to business operators, and so it's business. And for you to be able to assess the likelihood of a person suffering from a certain illness, it would be good to know what their lifestyle is like. And so if you have an Apple Watch that tracks your movement, or your phone, which tracks, how you move about during the daytime, how you operate in your house. I know in some instances there may be collection of data as it relates to, as we said earlier, just the items that you may purchase at the supermarket. And you could be buying for a friend, but it doesn't matter. That information now becomes your information once it is logged under your facial recognition data and your facial recognition information. It now becomes your information. And an algorithm won't be able to track or to trace that information to say, perhaps I bought 10 packs of sugar, but I'm only going to be using 2 and I'll share the other 8. An algorithm may not be able to identify that kind of social intervention or social lifestyle because that's not visible. What they're able to manage and process and in the future manipulate to provide assessment would be the information that is provided to the data. So as we see, just the gathering of information is very critical as we speak about the assessment of the technology and the use of the technology. So the realities of the age of AI. So Santa knows if you're being good or bad. Did Facebook sell my, and the son asked, did Facebook sell my information to him? And this cartoon is very critical for assessment because it looks at just our daily functioning and things that we may take for granted. You may have, for example, an ultrasound being done, and you may have been told that your child is going to be a boy, and then the child is being born as a girl, or it's going to be a girl, and then you have a boy. So it shows that even though you would have made so much preparation for what you anticipated based on the AI output of that assessment, it may not be what is in reality true. And so it is for us to properly prepare for that kind of, the eventualities wherein we use information that's not accurate to cast an assessment that may not be true or may not be real as we use AI in medicine. So facial recognition is big business. The research firm Market and Markets expects the global facial recognition market to be worth $8.5 billion in 2025. Now we are literally 2 years away plus from that, and this is big money. So we have a lot of persons investing in facial recognition technology because it will cover marketing, how you advertise to people, how you share information with people, and how individuals are able to function in their different space. Employers are using it, employees are using it, business owners are using it. Because the examples of facial recognition technology across the world, from this article in 2020, it states for security. And this is all the examples of facial recognition technology being used in our daily life. Security. The US-based drugstore Rite Aid Corp uses facial recognition in over 200 stores across the country to detect theft and alert staff about people who were previously engaged in criminal activities. In case of a potential threat, security agents are notified by their smartphones. Now this is Rite Aid is into medicine somewhat, and we're seeing where they are using a technology for security where you can identify a potential threat that you may deem to be somebody who would have been in a criminal activity previously. Just a few weeks ago, we had an individual on the news, a young lady on the news who may be pursuing a legal suit in the United States, I believe, or in Canada. We could check, do a Google search and check. But what was important was that she was arrested based on facial recognition information, and it was very inaccurate. And so she was arrested. I'm not sure if she was charged. She was arrested, and she may have to take action after proving that she wasn't the person of interest. So we see where it's playing a very critical role, facial recognition in security. Let's look at marketing. The India-based SpaceX provides a state-of-the-art facial recognition technology that helps retailers to measure the interest of certain products based on the customer's emotions and heat maps in order to devise targeted advertisement based on gender and age. Now, just to note what it says here, it says that they're assessing the customer's emotions. How do they capture the emotions? Is it from the facial data being collected from images, or just from you using your phone where there is an input from a camera system and then an output? Authentication. Android has a facial recognition app called Smart Lock, which allows smartphone owners to unlock their phones by holding it up to their faces. And I'm sure quite a few persons can relate to this technology. Payments. Alibaba, the Chinese e-commerce powerhouse, has integrated facial recognition software in its payment service. This is called Alipay. Chinese customers can now pay online by just showing their face to a computer vision enabled device called Dragonfly 2. This system is currently deployed in more than 1 cities across China. So imagine just literally paying your bill or conducting your affairs online by just showing your face. And I think that's impressive technology. Photo tagging. One of the earliest adopters of facial recognition technology, Facebook first started using it back in 2011. And this is photo tagging. Anytime a user uploads a photo, the company's facial recognition system systematically compares all of the faces in it with those of other users, the user's friends. And if a match is found, then it tags the face to say, is this person? Sometimes I would have had the experience before I knew about the data collection from photo tagging, where I would tag my friends once Facebook would ask, is this, say Sammy, I would click yes and add Sammy. So the examples above confirm that facial recognition technology has its hands in many fields and industries. Governments and private corporations are working together to perfect the technology and the sharing of big data sets with the faces being harvested. And so it's important to now speak about secrecy and perhaps privacy as it relates to the information being gathered. Whilst we ponder on the selling and sharing of facial data, a company called SenseTime, an artificial intelligence firm based in China, is selling facial recognition products to the Chinese police and the Japanese technology company, NEC. NEC supplies software to law enforcement agencies in the US, the UK, and India. So now this is just a general overview of the web of the sharing, processing, and even selling of facial data information. So see, we have a company called SenseTime all the way based in China, but they are selling information to various jurisdictions, various countries. And we see where information is also being used to, in the United States and UK as it relates to facial recognitions being collected and being sold for law enforcement and other use. Now, for NEC to be able to supply software to law enforcement agencies in big countries like the USA and the UK and India, there must have been a heavy collection of data and facial biometrics. My caution would be, if we are going in an area where we are going to depend heavily on AI in medicine, we must be very careful as to how we treat the implications of the sharing of the information. The information should be so confidential so that, well, before we even reach the area of confidentiality, the information must be so accurate so that we do not cast any, as I said, misjudgments as it relates to your health, your health status or your potential to be of a certain illness by just using a computer generated algorithm database. Now, good uses of facial recognition technology. Device security. I'm sure men would love this protection because they're always hiding their phones. So device security is very good. Facial recognition is good for that. Identifying genetic disorders. We have, for example, Face2 Gene app, which is able to scan your face and is able to tell if you have a genetic disorder, which is amazing technology as well. We also have, let me go back up a little. If you're buying alcohol, stores, for example, in the UK will use facial recognition to identify individuals to ensure that they're old enough to buy alcohol. Security at schools. In Sweden is now using facial recognition technology to call attendance. So in our school days, we had the teacher marking our school registry. Now in Sweden, you just scan your face and the student is registered present at school. In the US, facial recognition is being used to identify sex offenders. So we see where the technology is good. As we're saying, and we've been maintaining, it is the gathering of information without knowledge and without the consent of individuals, the errors in identification, the misuse of the data, general application of the biometric data, which is what concerns many. So how will the law protect me and my face? The law's approach to facial recognition technology. As facial recognition technology becomes increasingly pervasive, privacy concerns become real, and we now realize that the current laws do not balance the benefits and the harms. A recent development in the UK shows the government's commitment to providing guidance instead of over-regulating facial recognition technology. This position was exemplified by the Information Commissioner's Office paper, which discusses law enforcement and facial recognition use. Whilst these discussions are ongoing, the United Kingdom is looking to replace passports with facial recognition and will soon launch an application utilizing facial recognition. So can you imagine, soon you may not even need to travel with a handheld passport, because you may just be able to walk and be able to access crossing borders without restrictions once you're in good standing with your character, I will assume. In Australia, the country is cracking down on facial recognition companies, and there has been backlash in Russia over Moscow's new facial-based metro payment system. Now, as we're speaking, and this is more of a health forum, I do know that recently there has been major development as it relates to human enhancement. If you are unable to speak, if you're unable to walk, if you're unable to use your hands, you may be able to get human enhancement that may be able to assist you further with living a normal life. And this is very good technology, and the only way to actually be able to use the technology is to have the technology properly advanced. As we've been saying, we just hope that if you do have any disability, that you're not treated with any disadvantage, because you may not be able to work based on presumptions if it's shown that from your data being collected medically or otherwise that you may not have a limb or you may not have proper eyesight. We're just hoping that may not be used to judge or to discriminate against individuals in the labor force as well. In the United States, laws have been passed at a state level and local level to regulate facial recognition technology. Yet many educated citizens are demanding better regulations for the technology. The state of Illinois allows individuals to commence legal suit on the basis that it is illegal for commercial firms to use a person's biometric data without their consent. Will it be same in medicine? Will it be where a patient will say, you're not allowed to share my information without my consent, or you're not even able to gather any information on my person without my consent? And if they decide to take that position, will they still be open to healthcare, to healthcare services still? And this might be a bit legal, but it's just case law on what has been happening in the area of facial recognition information collection, where Facebook would have agreed to settle certain claims where persons would have brought against Facebook for the breach of of their privacy by collecting information from their Facebook pages. And we have a new law, which is the Biometric Information Privacy Act, which speaks to, and this is in the state of Illinois, which speaks to how information can be collected, and it strictly states that it should be on the consent of the individual. Now it says Facebook, read our new privacy policy. And this is very funny because even though there is this information, we still are uncertain as to how information is being stored, how it's being managed, because laypersons perhaps may not even care to understand how it works. But is my face a mathematical formula? And that is what it boils down to. If there is AI that can be used to look at your face and tell whether you have a disorder, then this is technology that can be used to perhaps diagnose you and then to treat you. And the question is, if there is any kind of inaccuracy, who will be responsible? Will it be the person who created the algorithm? Will it be the person who is using the algorithm? Will it be both doctor and nurses or anybody in this space who is administering this technology? Who will be responsible? And this is where the law is lacking, because we now need to have this discussion openly and that there be some transparency, because it is being used, the technology is being used, and it's casting certain assertions, certain judgments, certain assessments, certain, what I'd say, I don't want to say inaccuracies, but that is what the reality is. So who will be responsible medically for these operations or the use? In Florida, we had at the We Robot discussion conference, we were discussing healthcare with robots and just robots being able to conduct surgeries. And I'm just going to read just a snippet here of an article that I have, and it says that computers being initially used in clinical images for administrative work is very important to the world of medicine. A decision support system known as D-Explain was developed by the University of Massachusetts in 1986, which gives a lot of probable differentials based of the symptoms complex, and is also used as an educational tool for medical students. We have another app that is called Germ Watcher, and this is a system developed by the University of Washington to detect and to investigate hospital-acquired infections. That's very important. We have another one that is called AI Therapy, and this is an online course that helps patients to treat their social anxiety using therapeutic approach of cognitive behavior therapy. We have another one, and this one is the interesting one, and this one is the Da Vinci Robotic Surgical System. And this was developed by an Intuitive Surgicals, and it says that it is able to revolutionize the field of surgery, especially in gynecological surgeries. And it says the robotic arms of the system mimics a surgeon's hands movement with better precision than a 3D view, and it magnifies and allows the surgeon to perform, and it says, certain kind of intricate incisions. Now, I'm not a medical practitioner in any way, but for me, to have a surgical robot that has more precision than a human being is superb. This is really great news. And that's great advancement for humanity. Now, the question is, if there should ever be a time when this robot or this surgical system should fail, who will be responsible? If it's being operated by a doctor in New York whilst the system is in Florida, who will be responsible? If there is a computer company that provides internet service and we should have a crash in the internet service whilst the surgery is ongoing, who will be responsible? And these are the things that I think are very important for perhaps doctors to discuss, to have further discussions on, perhaps regulations, being prepared just to explore the eventualities of the technology being used in medicine. Now, just to conclude, regulate or ban. Do we create policies to avoid facial biases due to testing inaccuracies. The National Institute of Standards and Technology conducted independent assessment to confirm these results. It reported that facial recognition technologies for 198 algorithms showed facial bias towards women of color. And if we're having biases now for these algorithms, these are now algorithms and data sets that will be used in subsets, for example, in medicine, in education, in law enforcement. And if there are biases so early, how do we fix those biases so that we could have a clean, clear vision as to how we use AI in medicine? Will we have a computer system judging registered personnel or registered persons, and perhaps there may be a bias as to who may see the doctor first and who may see the doctor last, and which matter is critical and which one is not? And it may not be a concern in Jamaica because we're predominantly of the Black race or mixed race, but what will happen in a white state or in an Indian country or in a Chinese country? Will there be discrimination based on the system of recognition? Another conclusion, do we create policies to avoid facial discrimination in law enforcement? And I won't go too much into this because law enforcement is separate now, because our focus now is on the medical aspect, but this nonetheless is still very important. Now, another element in concluding is data security, to secure data privacy. This, speaking, just generally, may be very challenging, especially where data is being collected by government agencies and entities, because just like the testing that was being done by DARPA with the facial recognition algorithm at the Super Bowl, we may not even know when these tests are being done. If they are being done medically, will we know? If they're being done on an educational level, how will we know? Many of the times we only know when the experiment is done and there is evaluation and assessment, and that's when we know what the results are. So there's a lot to contemplate, I believe, as we speak of medicine and healthcare in AI. As I said, we can look forward to a future of having robotic psychiatrists. Ms. Joan Pransky, my friend, was the first, self-declared robotic psychiatrist, but we could check her work. How will the interaction be with, just general nurses and doctors managing an operation room where we have robots? Will they be able to relate similar to humans as human to human would relate? And if there is any employment concerns or in the whole delivery of medicine, who will be responsible? I will just wrap up quickly by just mentioning briefly, and this may be, I'm glad now it's not such a sore point of discussion like it was a few months ago, but just for example with the COVID vaccine too, wherein we had one side saying it should be mandatory, have another side saying it shouldn't. But as we now know what technology is and the ability to actually edit your genome, there is nanotechnology, there is so much advancement with technology. The reality is, though the technology is very good, there is still concern as to how the technology is used, and will any group be responsible? Will there be shared responsibility? And also the question is, will there be security that humanity will be taken care of and treated with utmost respect as we traverse the space of science? So if there's any questions for me, I'm open, and that's the ambit of my presentation. Thank you so very much.
Thank you very much, Ms. Smith. Colleagues, are there any questions?
No, not seeing any questions at the moment.
Just one or two comments that are in the chat. Colleague commented that it's very frightening. All that can be done with theft of the face. And the other one is that the technology has its place. However, human beings will get lazy. That's just a comment in the chat. All right.
Well,
so
one of the things that I saw come up a while ago was a question from Dr. Arna Brown Morgan about a woman being arrested in the United States recently. when the facial recognition was what they used to say it was her. However, it was proven that it wasn't her. Isn't there a problem as well for persons of our ethnicity, in that we're learning as well that facial recognition tends to not properly recognize persons who are darker than Caucasians?
Yes, that's a very good question, and that's the sad reality that we're facing now, because the data sets being collected a lot of the times, or the experiments being done are being done predominantly in spaces where we have different races, not so much in Black communities, and if it is for Black communities, it seems as though it's more leaning towards identifying Blacks as perhaps criminals or people of color. I won't say Blacks as people of color. So that's really a great concern. Even I was doing just an assessment with just how we eat as well, when I learned about the tracking of the technology and how your information from your shopping list being used by insurance companies to balance how your premium will look like for the forecasting if you're going to be ill based on your lifestyle, your eating lifestyle. And if we do check, in most communities, most Black communities, you have a lot of fast food chains, and they're available. And if that's always popping up on your credit card or on your bill, chances are you're going to be slated to have a certain kind of illness in the future. And so you're not going to have an increased premium for insurance by just the way how you are eating. But there's no other option as to how you eat. There's not much health food stores around, and so on. So it really is a frightening reality. Gene editing too is very, very crazy, because you can literally, perhaps change your whole genome and how your child will look, if you want them to have green eyes or blue eyes. If genome editing is advanced on that level, then it could be, real big changes. Humans may just look very different in the future, just look very different, or human enhancement. If I have a robot feet, how should I be allowed to enter a sport game, and if I do, what restrictions are there, because that perhaps not be able to compete with humans running. So it's just the balance. Or if you have a different heart or lungs, how do we balance that with just the human lifestyle and how we are now naturally? So it's a new world. It's a new world that we're going into.
Thank you very much. Did Sister Campbell manage to reconnect?
Yes, she's on.
I did, thank you. My internet completely shut down, but I'm back.
All right. So once again, let us thank our lawyer for her presentation, a very timely one, and a lot of food for thought. Over to you, sister.
To me so quickly. All right, I hope I can just pick up where we left off, where we were, real life. And I think, yes, this is where we were. So one of the most laborious things in an intensive care unit is time consuming and laborious. Sounds easy, and it's calculating of the shift or end of the day values that are a patient input and output. And with the use of technology and the electronic health record documentation, it would be a little bit easier, because the technology would do the calculation. The challenge still remains, however, that if the incorrect information is inputted, then the calculation will still be incorrect, because that information has to be put in the record for it to be calculated, but calculations would be easier. And I think we alluded to the COVID-19, how it allowed us of necessity to use a lot more technology than we would normally use. So we use the technology to remotely monitor patients. We use the HIMS system, which is what is used at the university hospital. Wasn't out in full, but we used it because we were in a pandemic to do documentation as well. So we remotely monitored patients and we also documented electronically. So that's a benefit. And when we come to the benefits, which we'll go to shortly, we'll see that that's one of the benefits of the technology in times of disasters and pandemics. Then we can use it to our benefit. Challenges and considerations in the use of technology. The ethical and, it's been said and said again, ethical and regulatory systems. Who will be in charge of the system? I think I'm not in, sorry. Oh my, sorry, I wasn't in presentation mode and I came here. So let's see if I can speed up where we are. And trust from highly suspicious medical practitioners. So as we have seen and heard in the chat, there are still a lot of us who are, we're not so accepting of the technology because you're not sure who are the monitors, what are the, who is putting in the information that you get, who is going to be responsible. Like the lawyer just said, Smith, who is going to be responsible if you may. So we are not very trusting of the technology because you're not so sure who puts the information in, who is monitoring it, and that sort of thing. And I think it was our first presenter spoke about interoperability, the availability of the interconnectivity then of the system. Will I be able in ICU to send a message to somebody in, say, gynae, and how is this going to be transmitted? Is the system so connected that it will work? And we at the university, they've been rolling out in different departments what would be the electronic health record documentation system, and it's slowly going. And we can already see the challenges because I am using it, but somebody else isn't using it. I have access to one thing, somebody else doesn't. So, it is not very user-friendly, and the interoperability of it isn't there as yet. Patient safety and accuracy is another challenge. Data security, patient privacy, and the security of a vast number of patients' personal information, which can be exploited. So who is going to be monitoring this? Who will have access? Another challenge is a poorly integrated system, which does not allow the practitioner at one health facility to have access to the care and the treatment previously received by a patient in another facility. And adopting new technology. Most of us, if not all, are still on the learning curve. A lot of this information is new to us. There are so many things that I learned in doing this presentation. And one of the things I found quite interesting was a lot of the information we are getting and that I accessed was through the UK, the United Kingdom. And they are currently in the process of, they've planned a summit for, I think it's November this year, to look at how artificial intelligence, how that will be used, who will monitor it, and they're taking the approach of an international forum, because all of us will have to, be a part of the planning and decision making, given the nature of this and how exploitative it can be, who will monitor and who will be in charge of monitoring all this data that we have access to. But what are some of the benefits of the technology? We'll have improved patient monitoring, remote patient monitoring, faster diagnostics, data-driven insights, personalized treatment, real-time communication, predictive analytics, efficiency and workflow, medication management, educational resources, surgical advancements, patient and family. If not all of these, some point during the presentations today, one of these, this will benefit us in this technological age. The disadvantages, though, are just as many. And I'll be the first to speak about the technical failures, because the internet is a very big part of, you know, what we do in terms of technology, how we pass on information. And if we have technical failures, how will this impact our care and management, data privacy concerns, dependency and skill gap? One person commented that nurses will become lazy, doctors will become lazy, you know, because we are so dependent on the technology. Distraction and overload, we become more focused on documenting and looking at monitors that we're not looking at our patients. Lack of human action. And that's one of the things that came out of most of the studies that were done coming out of COVID, was the lack of the human touch, you know, that was missing. And it will take us a while to, you know, move on from that we are moving to a different age where machines and robots are gonna be an integral part of what we do going forward. Misinterpretation of data, high initial costs to set up, and we are experiencing that right now. You have an ICU with 8 beds, you need 8 computers. Well, twice that amount, because you have persons coming in to see patients. Everybody needs access to a device. Compatibility issues, so your skill set is not there. Ethical dilemmas, overemphasis on technology, patient disconnect, information overload, lack of personalization, and health inequities. These are just some of the disadvantages that we can see coming out of the use of technology. And what are some future trends that we're looking at? Sorry. Yeah. Future trends, we must look at the available technology to assist us in making the things we want to do. And there are many things we want to do that technology will assist us to do. As it is now, we're struggling with AI, struggling with the computer, struggling with the system as it is now. But going forward, there will be a whole lot more, because we're looking at things like wearable devices. A lot of us have a smartwatch, but we just use it to monitor ourselves, you know, what we're doing, how many steps per day, did I get up enough today, did I drink enough water? But for the future, we're looking at things like your wearable device being connected to the electronic health record system. So the amount of water you drank today, your blood pressure today, all of that will be inputted into your medical records, and your doctor or your practitioner, whoever, will be able to get access to this information. Data analytics, the information that is put in is collated, and wherever you are in the world, whichever doctor you see, they'll be able to look at your information, because everything will be intertwined. And we spoke quite a bit today about virtual reality. So in conclusion, in critical care units, relative to high staff turnover, junior nurses, decreased number of senior nurses to supervise junior and new staff, foreign nationals who need additional support to function in the critical care setting, technology can offer this support. The integration of technology into critical care has ushered in a new era of healthcare, delivery, real-time monitoring, and enhanced precision. While technology brings immense benefits, there are concerns, including data privacy, technical failures, and the need to maintain that human touch. There is help available. But as we move forward, policymakers and stakeholders to ensure that technology remains a means to an end, serving the ultimate goal of helping to provide optimal patient care. Ethical considerations, continuing education is pivotal to harnessing the full potential of technology. In this digital age, let us embrace the changes, remembering that behind every piece of technology lies a living, breathing patient in need and deserving of the highest quality of human expertise technology can offer.
Let us thank Sister
Thank
Donna Campbell for her presentation, and we say amen. Somebody put in the chat that the human touch is a part of healing, and we are cognizant of that. Do we have any questions for Sister?
No, I'm not seeing any questions in the Q&A at the moment.
All right. Okay. So our next speaker, is he back with us? Dr. Romario?
Not as yet. We're going to go
Not
to
as
the
yet.
after.
Information is that doctor had to go off to the labor ward. And so we will move into the presentation, Unlocking the Digital Smile, how technology is reconceptualizing dentistry.
I'd like to say a special thank you to the Jamaica Association of Nurse Anesthetists. Thank you so much for the invitation. And I am just going to spend a few minutes with you this morning sharing how the digital era has impacted me as a dentist. So let's get down to business. Healthcare in the digital era. And I would like you to take a look at this telephone screen to the right of my screen. There are days gone by when we picked up the phone, put the receiver to our ear and mouth. There was a round dial that we dialed each number and waited for that dial to go back to the original position before we dialed the other number. And what we did on the phone was speak. That was it. Today we walk around with mini computers, and at the end of the day, it happens to have a phone. Well, people are accessing information not even on computers anymore. They are looking to get quick responses to any question or to be connected anywhere as conveniently as possible. And this is what quite a few of our patients use now. So let's talk a little bit about unlocking the digital smile, how technology is revolutionizing dentistry. Now, rapid advancements in technology have revolutionized the way we connect, diagnose, treat, and care for our patients. When I was growing up, it was the thing to go to Mr. Chin shop. Every neighborhood had a corner shop. And if it was lunchtime, at that time, I think the primary school that I went to allowed us to leave the property. And sometimes we'd run up the road to Mr. Chin shops. Mr. Chin, sell me 2 bun and cheese and a box drinks, please. It was the common thing to say. And this corner shop was not just a shop, because the shop owner knew you and your parents and your next door neighbor. and you knew Mr. Chin and his family, and they had been with that corner shop there for years. So it was very relational. Sometimes as a child, if you didn't even have the funds, you could say, trust me, a bun and cheese. And Mr. Chin would take out his little notebook and record all the activities, all the purchases. And at the end of the week, when your mother come in, she would set the debt straight. She would cover whatever was outstanding. It was very relational. Well, we kind of moved away from this relationship to one that has become so impersonal. You know, you call somewhere now and they give you an option to choose 1 to 4. And when you choose that, there are another set of numbers you have to choose 1 to 4. And if at the end of that you don't get through, you can dial 0 for the operator. Or if you're like me, you look for 0 before you even start the process of going through all of those. Why? So that you can actually speak to a human being. Because speaking to a person is extremely important to us. We feel as if we're being heard. Well, I'm going to switch gears to talk to you about something that looks quite different from Mr. Chin Chop, but it's very similar in how it behaves. I really was not a big fan of social media simply because I just felt it was just too invasive at times. People were just posting too many things that everybody did not need to see. But maybe about 15 years ago, I attended a dental conference, and one of the speakers spoke to us about marketing. And the tide has changed. People are not using a phone book. Even the yellow pages online is not being used the way people would think it is used. People want a view into who you are before they make any kind of connection with you at all. So it's not unusual if people want to go out to eat to go on IG or Facebook or some social media channel or platform and look for you. And if you are a place that serves food, they want to look and see what the presentation looks like before they even make a decision to walk through your doors. Yes, they are looking at you. They are looking at the place. If there is interaction with the staff, they're looking to see how people gel. And you'd be surprised to know, sometimes when they're coming to you for the first time, they may know the names of the team members. If that information was shared on the IG, they may be familiar with the layout, because although it seems one-sided, they are actually forming relationships with us and our offices before they step through the door. So social media really builds connections for business success. And I know this is a medical group here, and I know that you don't do things the way that merchants do things, or people who have small businesses selling food or clothes or whatever. But can I let you in on a secret? Your clients do the very same thing for you if you have a private office. If you're strictly hospital, that may not be the case, but people are looking you up. They're looking at your reviews. They're making decisions as to whether they want to come for care based on how you present in this digital world. So before people even come through the door, they're looking to see how you present. If this is a place I want to form a relationship with, how have other people felt who have sought your care? And then finally, they'll pick up the phone to call to make an appointment. Or if you have a website where they can make an appointment from online or any other platform where they can reach you, they'll do that because convenience is key as well. Now, before we get into the nitty-gritty of dentistry, we've spoken about how the digital era allows you to connect with patients before they walk through the door. Now we're moving to the next step, where I call this step practice management. There used to be a time when I would get an appointment book, very fancy, from one of my colleagues at Christmas time. Now, I don't even know what an appointment book looks like because everything is digital. When someone calls to make an appointment, they're scheduled. When I need to make a treatment plan, it's entered into the system. When I want to make sure that patients are reminded of their appointments, we have systems that use AI to send an email depending on the time that we want the patients to be aware. It can be 1 month out to say, hey, next month you have an appointment with us. And then it can be 2 days before, reminding you of your confirmed appointment in 2 days. And then it can be on the day off, just confirming that you're on your way for your X appointment at X time. All that can be done in advance to ensure that when you schedule a patient, that they keep their confirmed appointment and that they show up on time. And finally, we can track our patients. If someone has missed an appointment and they did not reschedule immediately, we have softwares that can let us know who are the patients that are overdue and by how much are they overdue. In a dental office, it's the routine thing to see a patient every 6 months to do a thorough oral examination and to clean their teeth. And if someone has missed their 6-month appointment and we forget, they can fall through the cracks. So these software programs allow us to be able to see who missed an appointment, how long it's been since they've been in the office, and it allows us to take care of the part of their life that they have given us permission to care for them. So that means people are looking at us before they come in. When they come in, we can schedule an appointment immediately. We can look at each day. You can see that the scheduling form has different colors for different providers or different types of procedures. So everything can be so organized that you look at it and you can assess how your day is going to unfold. Many times when I'm doing my treatment planning, not only am I looking at it myself, but sometimes I may want to share it with a colleague to review a particular situation. And at the end of the day, the treatment plan is inputted into the system, and that can be shared with the client, as well as we can keep track of the procedures that are upcoming and the order in which they are scheduled just by looking at the treatment plan. And connecting is key. Gone are the days where you tell 10 people to come in at 8 o'clock and you hope that only 6 of them show. Time is extremely important to our patients, and so we have to be as efficient as possible. So we're going to identify a time and we are going to commit you to coming to that time on time. And so our tools will do whatever they can to ensure that that happens for you. And finally, if you happen to fall out of your system, fall out of your schedule, we have an app for that. So let's move on now to digital imaging. There used to be a time, well, I still have it, but I don't use it, where I had a dark room. So we would use the traditional X-ray films. And after the X-ray was taken, we'd go to the dark room and we'd process each film individually, and then we would wait for them to dry, and then we would mount them in a particular order, and then hope that we would see all that we need to see. Well, now with the digital era, things are more efficient, things are processed a lot faster, and they are larger than life, and the images can be looked at from different views. We can manipulate the images to focus in on certain areas. So what you see with this big funny looking machine is actually a scanner. So we have small phosphor plates. They look just like the traditional dental x-rays, but the image is placed on those small plates, and then each one of those plates is put through this dental scanner. And if you look to the left of it, you will notice that there are x-rays in a particular order on a large screen. So now we're looking at the x-rays on a monitor, as opposed to having a view box that had light behind it for us to look at the traditional x-rays. Each one of these can be enlarged, and it's much easier to see any defects, any abscesses, any decay between the teeth when something is enlarged. On the other side of this image, you see something looking like maybe a mouse or something. This is actually another way that we can take x-rays, and it's a digital sensor. And that digital sensor is a little thicker, as you can see, than the traditional x-ray film. But this sensor captures the image once it is put in your mouth. And again, it can make the image captured larger than life. And there are ways that we can zoom in, zoom out, and make a better diagnosis than the traditional films. Now, this is a little bulkier than the phosphor plates. The phosphor plates seem to, well, it is said that they're not as sharp or diagnostic as the sensor's image. I work with the phosphor plates. I see far more than I used to see with the traditional films, and it works just well for me. Those sensors are very sensitive. If it falls, if the patient bites hard on it, it could be damaged, and to replace one, it costs a pretty penny. So most offices, or quite a few offices now, are moving away from the traditional films and going to some form of digital imaging. Well, of course, AI has entered the world. And now, if you look to the image with all the x-rays on display on my monitor, I want you to realize that now there are softwares that can overlay color on my x-rays, and color codes allow patients to see specifically teeth that are filled, teeth that have decay that's just starting, teeth that have decay that is more advanced. And if you look closely, you'll see some measurements, because now we're looking to see where the bone is. Do we have bone loss? If the measurements are in that light green color, they're within the normal range. If they are reddish, we know that we have bone loss in that area. This is extremely important to me because I do all my consultations via Zoom, just as I'm speaking to you now, and I will pull up my patient's x-rays, share the screen, and we will enlarge each one of these images and go through and speak about what is existing, what needs to be done, what are the options. So bringing it to color makes it so much easier for the patient to see what I'm speaking about, rather than hoping that they can see the dark spot between the teeth where there's tooth decay, or see what I'm talking about when I'm speaking about bone loss. These are two different companies, so the picture on the bottom has a different color code than the picture on the top, but they're essentially doing the same thing. Now, an X-ray is a two-dimensional image. Cone beam CT gives us three-dimensional imaging, and that is extremely important for many things, but we use it quite a bit when we're looking at placements of dental implants. Now, as you can see, the image that is brownish, goldish, really does look three-dimensional. You know, it looks very different than if an X-ray was taken of this area. But if you look to the other side, we are able to see the height of the bone, the depth of the bone, where the implant could be placed without interfering with the inferior alveolar nerve, which runs through the mandible. We'll be able to see how long the implant should be. So there's quite a bit of information that can be gathered by 3D imaging. In my office, I do not do 3D imaging, but if I have had a discussion with a patient and we're planning to do implants, I will refer them to the oral surgeon who will do an initial evaluation, which will include taking a cone beam CT image, and then that image is sent to my lab, because the lab has a software to open this cone beam CT and plan where the best place for the implants to be positioned are. So we are a team. The oral surgeon is working with me and the lab is looking at the cone beam CT, because the lab now has to prepare a surgical stent so that when we place the implants, we're getting the best functional position where the bone is best to accommodate this implant. But also aesthetically, we want to make sure that it works well, but it also looks good. These implants here are on posterior teeth, but we do implants on anterior teeth all the time, and aesthetics is key for anterior teeth. So this is what a surgical stent looks like. The lab would take an impression from that I would send to them and use the imaging sent from the oral surgeon and create this surgical guide. As you can see, these two areas closest to you have a metal lining, and so it allows the surgeon at the time of placing implants to put this in the patient's mouth and be guided to put the implants at the most ideal place. So the team of the general dentist, the oral surgeon, and the lab work together using the digital era to make it work as efficiently and effectively as possible. Now I'm going to change gears a little bit, pull back. This is a dental camera. They say a picture is worth 1,000 words, maybe 1,000,000 words. there is a way in which, even if somebody's telling you that something is going wrong, if you don't feel it, if you don't feel pain, you question if it's really so or not. When somebody takes a picture of what's happening and they enlarge it, the size of a monitor, and you can see for yourself, no questions are asked. You receive confirmation that the tooth really is broken. There really is a hole in the tooth. So it allows, again, the patient and the doctor to look in real time at what's happening in a place in your body that you can't readily see. So the thing looking like a pen is actually the intraoral camera. At the tip of it is a small camera, and that connects to the computer, and you can see it enlarged, just like how you are able to see enlarged x-rays. So the digital intraoral camera is not something new. It's been around for numerous years, and it is a tool that helps in the treatment planning because the patient is able to see and really appreciate what you're looking at. But some companies have taken it a step further. So they'll take images of what your teeth look like now, and then they have software programs that can predict how the end product will look after you've done all that they have treatment planned to do. So the before picture, which is the one that is above, shows what we're looking at in real time now. And the software can show what the end product should look like at the end of treatment. Now, the challenge with this is people can go, oh, I love this. I want my smile to look like that. Or it can backfire on you when the smile doesn't look exactly like that. Cosmetic dentistry has a lot to do with beauty being in the eyes of the beholder. Yes, we have some guidelines that we should follow, but at the end of the day, each person can like or dislike the same thing presented the same way. And so you run the risk of somebody feeling that it doesn't look quite like the picture. Well, these are the risks that you have to take when you're going to allow a software to predict what the outcome should look like. Now we're looking at dental scanners. The picture with that pink stuff in the tray is the traditional way that we take impressions. So that soft material in the tray would be placed in the patient's mouth. It would be allowed to get hard, what we call set. Then we'd remove it, and now we can either pour it up with stone or send it to the lab to be poured up with a harder material. We refer to it as dental stone. And then they would have a working model of what is happening in the patient's mouth to do whatever the procedure is that we're asking them to do. Sometimes it's making a crown, sometimes it's making a denture, any number of things. Well, let's look at the dental scanner now. It literally scans what is happening in the mouth. It takes several small shots, and they together put together this three-dimensional image of what is happening in the patient's mouth. It is cleaner than the impression tray. With skill, I don't know that it's shorter, but it can be more accurate. It's an image that can be maneuvered. You can turn it upside down, look at the side. And so once you have a scanned image, There are several softwares that can do various things with the scanner. A dentist can scan and send the image to the lab, and the lab can then fabricate the appliance from the scan without anything tangible, nothing that you're holding in your hand, just image sent and image used to fabricate the appliance. But now we're going even a step further. We are using the ability to do 3D printing in a very specific way. So the CAD/CAM system uses the ability to scan something that you want to repair or to cover. So if you look closely, you will see an image of the mouth that has been scanned. And then the scanner guides the milling machine as to how to produce this 3D image. So now you can see this just white chunk of material. Most times it's a form of porcelain, and the technician will put that chunk, that square, that die into the machine, and then you can now see a close-up of the machine milling the crown based on the information sent from the 3D scanner, and you end up with a crown that is made strictly in the dental office, and not in minutes, but in a much shorter period of time, being complete and ready to be placed in the patient's mouth. Very convenient. I think that they have improved the technology over the years, so it fits well. However, my one drawback to this is teeth are not the same color. One tooth can have one color at the tip and a different color near the gum line. And at the end of the day, there are several colors on the one tooth. With one block of material, you're limited as to what you can do. And so you can have something that is convenient, but you may lose out a little bit on the aesthetics. There's lots more that we could talk about in terms of the digital era, because our specialists, the orthodontists, also use scanners, and those scanners allow them through a software to create aligners that can straighten teeth gradually over time. So how has the digital era affected dentistry? The digital age has reshaped the very canvas on which dentistry is practiced, where 3D imaging, virtual simulation, and CAD/CAM systems create a dynamic tapestry of precision, artistry, and patient-centered care. You have been a wonderful audience. Thank you so much. And as we would say in our Jamaican vernacular, walk good.
That's the end of the presentation. Thank you so much to Doc.
Thank you very much also, Mr. Sam. And that presentation was also very timely. And it reminded us that even as we are in the digital era, there are some things that you still must do. So you still have to get to the dentist. Right. So did Dr. Romario get back, Mr. Sam? Is he?
Unfortunately not. Unfortunately, no.
Okay. Then it would mean that we have come to the end of today's activities. And at this time, I just wonder if there are any questions or any comments that anybody would like to. There's a final chance to get this, any clarification from any of our panelists. Any comments that you would like to make? I'm seeing a few of them in the chat. And that being said, I'll take this opportunity to express my sincere thanks to all our presenters and to all the audience. Without your input, this session or this webinar would not have been the success that I know it is. It's a lot of information, and I'm sure that everybody has learned something, and that is what these things are all about. So without further ado, I will hand over to the moderator, JANA's moderator, Mrs. Education Moderator, Mrs. Maxine Nicholson.
Okay, I must apologize. Are you guys hearing me?
Yeah, hearing you clearly.
Right, I must apologize. I was trying to get Dr. Romario White, who was called to labor ward. So that's an emergency that he had to deal with. I was hoping he would be finished just about now to present. So he was just asking me what time, and I told him just now. So far, let me just check one more time if he's on. Yeah, go ahead. Okay, I'm not seeing his response. So I'll just close off at this point. I want to say my 3 words right now are whoa, whoa, whoa. What can I say? First, let me say thanks to our moderators for such a lovely and lively coverage of the day proceedings. The presenters who did such an excellent presentation from start to finish. The ball started rolling from beginning to end with interesting presentations, and we are absolutely grateful and want to give a round of applause here for a job well done. Very grateful for the areas covered, with focus being on the digital era and artificial intelligence in healthcare. We have moved a far way and we're still going far where this is concerned. We have some concerns, yes, especially with the facial theft. People can steal your look and use it. That's frightening. Not like fingerprint where no matter what you do, you cannot get my fingerprint. And then again, if I get fat or if I lose weight, my facial features will change. So how they're using that, I'm not so certain. We learned as much as we could from the presentations.
Apologies. So today has been a day filled with some technical glitches, mostly from our ISPs, Flow/Digicel. As you would have seen, a number of our presenters have some internet issues. Unfortunately, Nurse seems to be having the same internet issues as well from her location. But if I could just be so bold as to say a warm thank you to everyone who registered and attended today's wonderful session. I think Nurse is back now. Yes, here she is.
We have been having some issues from morning. I'm not sure what is wrong here. Special thanks to all the presenters for doing such a marvelous job in bringing across healthcare in the digital era. As we move forward in the new era, let us try to make changes for success and betterment in the health sector. Chart a course that others will follow and emulate. Practice at all times to give of your best as you go forth. Once again, I want to say thank you all for being a part of our webinar and making it such a success. See you at our next webinar in 2024. May God's peace and blessings go with you. Thanks so much, Mr. Heron, for carrying us through. You have done it before, and you're still with us, and I appreciate that. I want to say thanks also to Indus Life for helping us through sponsoring and giving such a nice talk. And we hope we'll get to support your products. Thanks, everybody. Have a good evening.
Thank you.